May I have your attention? A warm welcome to one and all on this first program. In fact, today we are going to have a series of many events. And the most exciting of the events is the Curtain Raiser ICNC 2024. The Curtain Raiser ICNC 2024 is a very special event because it is organized together by Navi Mumbai and the Mumbai IAPN chapters. So we are very happy to invite one and all to come to this Curtain Raiser. Besides the Curtain Raiser, we have a number of scientific sessions all organized for us. And today is the first of the scientific session that we are going to have on transplants. Transplants has been very close to dietitians because we have to deal with the patients right from the pre-transplant, post-transplant, and so many other aspects. So today we are going to begin with the liver transplant. We will follow this series with other transplants. We will also try and include many other organs, whether it is heart and lung transplant, it is other transplants like kidney transplants, and many more. But today, for this first liver transplant session, we have very important and very, guests who are expert in this. We have none other than we have Dr. Anil Singh and Dr. Chetan Kalal. Both are experts in their own ways. May I have Dr. Chetan Kalal's slide on, please? Okay, so while we wait for the slide to come on, I will just introduce Dr. Chetan Kalal as a good friend because we have worked together in the past, and he's the program director of hepatology at Max Nanavati Hospital. Dr. Chetan Kalal is going to chair this session, and we welcome you, Dr. Chetan Kalal. Please have a seat. Dr. Chetan Kalal, I would like you to invite Dr. Anil Singh for the session.
Thank you, Eileen, for this introduction and wonderful chapter that you are going to start. So it's my privilege and honor to invite Dr. Anil Singh, who is not only my friend, but is a very astute clinician and is a director critical care and liver transplant anesthesia at Max Nanavati. So he's one of the pioneer who started working in anesthesia in the field of critical care, especially in liver transplantation, since the inception of transplant program in India. So it is one of the rare breed that we have amongst us. I welcome Dr. Anil Singh. Please, you can proceed and start your.
First, I'd like to thank Dr. Chetan for such a sweet introduction. So, and like, we have been working since long. He is maybe 3-4 years junior, but in hepatology, he'll be far higher. We are both from ILBS basically. So yes, we've been working only in liver transplant and critical care since 15 years. And I think he's the first DM hepatology of Maharashtra. So yes. Okay, enough of praising both. So good afternoon to all the beautiful ladies out here and my friends, obviously colleagues. So here we are. Eileen, thank you. Thank you, Sneha. Thank you, everyone, for just giving this chance to speak here. So the topic given to me by Eileen is something I think I would have done something wrong when I was at HN. Because MELD for dietitian, there is no connection of MELD and nutrition, leave alone dietitian. But I will try and do justice to it by telling about a little bit about transplant and about MELD and try and connect it somehow possible, whatever. Okay, can I get my slides? It's just logged in. Can we do that? Can you see the slides? Yeah, so the topic, so everyone knows now. There is no connection to start with. In the end, also, I'll say this word only, there is no connection. So what is liver transplant? So it's the only option a patient has when the liver is almost gone. So almost gone, in his words, he'll say there is no percentage you can say that liver goes, but I'll take his words only. He says that when 25 to 30% of liver is left, then you start having the symptoms of ascites, coagulopathy, and that is where and when it is irreversible, the only treatment left is liver transplant. So that is something which is right now also in evolving phase. I would not say that we are there, but yes, we have come long way up due to good immunosuppressions and everything. We are really close to reaching where we should. So it's a boon. Now I'll tell you how the liver transplants are basically done. There are two ways. One is your live donor, one is your cadaver. So how the live donor works. Does anybody know? Let's make it interactive because I don't think we should teach or there's nothing to teach. So anybody knows what is live donor liver transplantation? HN people should know. So I think all are HN only. No, see, there's an opposition also. I knew it. That's why I said. Okay, then HN, anybody? Live donor? So live donor itself, like it says, live donor. So there is a person live who is going to donate. So can anybody guess how much percentage liver is being taken out from the donor? Wild guess. 5%. Chocolate, 5%. Wild guess. That's why I'm saying wild guess. 20% taken. Anyone else? Up. Go up. Up. 70%. We take 70% of the liver from the donor, only 30%, which is required for a normal human being to be having normal liver functions for that period. But touch wood, thank to God, there's a mechanism that liver regenerates by itself. So within even 3 days or 4 days, we are back to almost the function which we require. And 6 months or 7 months, the size back to normal. So that's the best part of the liver, that we have these things going for the liver. So this is live donor. And the live donor means it has to be a relative. People come and say, sir, liver dila do. उनको ऐसा लगता है कि liver यहाँ मिल रहा है, उन्हें शायद हमारा ही liver ले लो भाई. That's the only thing we can do in the end. But this is a पैसा ले लो, liver दिला दो. अरे liver कहाँ से दिला दो? Then comes the cadaver donations. Anybody, any idea about cadaver? I think all transplants usually. So there's a donor, brain dead. Exactly, that's the word. Brain dead donor. So we need a person who is brain dead. There are procedures by which you certify them brain dead. Then you look for the organs which can be utilized if and only they allow. Zabardasti nahi le sakte hain. So we do that. There's a protocol to follow. There is a zonal committee which takes care of. Then there's a list. There are patients waiting in a list. So according to the list, there's a blood group of the patient. Usually livers match by blood group. Kidney, heart, and other transplant, we need to match HLA matching as well. For liver is the best organ. It doesn't need anything else. It just needs blood group to match. खून ज़्यादा match करने की ज़रूरत नहीं है. बस दे दो. Liver इसीलिए फायदा है कि even just the blood group matches, you can go ahead and do. But still in India, there is a lot of scarcity of these organs. So I would, along with this, I would like to promote that please, each and everyone go in society and tell, don't waste your organs. Don't waste your relatives' organs. They might be required for your own family members, your own relatives, maybe yourself later on someday. So promote it so that you don't, in the end, are looking for something which you may not get. So just promote from now. So I would request everyone to go in societies and do the promotion of this thing. It will help grow, save lives. So please do that. So now how the list is made. So listing is based upon how the bad patient is, not in India. In India, whoever comes first, we list him and he gets the number. So the MELD is something which tells you, which prognosticates. So outside India, US, UK, how bad is the patient? Accordingly, you list him. So that prognostication is by MELD. Now MELD sodium. So that is why the MELD comes here. It is just to prognosticate and to list. That is where the MELD is used. We're using it further, trying to modify it continuously. But right now, it is just for listing and prognostication of the patient. Like I said, MELD is used for, it is a model for end-stage liver disease to tell patient, to list him, what to do, whose number comes. Like again, I'll repeat, not in India. In India, line mein jo pehle aa gaya, utha lo, kha lo. It is like that. So yes. So what all is included in MELD? MELD has INR, it has creatinine, bilirubin. These are constants. Now we have sodium and fibrinogen, which changes, and that can change the whole MELD. So MELD sodium, there are a lot of MELDs. I will not go into it, but we would just stick to normal word MELD, right? So this is the prognostication which we do. Slides, yeah. So if the MELD score is between 6 to 40, basically. So if it is less than 17, the 90-day mortality is just 2%. But do you know there's a cutoff mark where we decide for transplant? Anybody has an idea of when we say MELD, itne mein you should go ahead and do transplants? Guesses again, come on. Wild guesses. It's between 6 and 40. When do you say the patient has this much MELD, he should undergo a liver transplant? Above 25. Any other guesses? बहुत late हो जाएगा.
Somebody from here said right.
No, not 40. He heard something close to it. See what rhymes with 40. Yes, you are very close. 14, 15 is, he heard 40. He thought it is 14. So
Somebody said 15.
yes. So, right. So at least you have that MELD. Then you go ahead and give him a chance. Because see, MELD of 17 to 20, there is 3 to 4% chance of mortality. But this is only 90-day mortality. As you grow, MELD the liver patient will decompensate very suddenly. If there is even a single trigger like sepsis, bleed, or anything, he will suddenly trigger. So these all things go out of window. So if somebody is having a criteria of liver transplant, please go ahead and do it when he's well. Because as the MELD grows higher, your chances of survival becomes low.
Can I add here something? Sorry, I'm interrupting Anil, but just for the sake of audience. So what is MELD? MELD is basically nothing but model for end-stage liver disease. Okay, so as in the name, it's a model which was initially used first time by an Indian. His name is Patrick Kamath. He's from Mayo Clinic, and that model initially was established to predict short-term mortality in the patient, those who are undergoing TIPS. Okay, but later on they found that this model is equally effective even for the prognostication of decompensation and overall mortality because of the cirrhosis. That's why since 2002 it came into picture. So the lowest score is 6, maximum is 40. So lower is the score, better is the liver function. So it basically based upon 3 parameters: bilirubin, INR, and creatinine, out of which bilirubin and INR is usually denotes you the liver function, and creatinine is a reflection of organ dysfunction. So it's a combination of 3 factors. So up to 10, we say that this liver will do well, and the probability of transplant is very less. Between 10 to 15 is a gray zone. So you may or may not require transplant, and more than 15 transplant is needed. So that is the time where you should prime the patient that transplant is needed. And as the MELD advances further, so more than say 30, 40, MELD is capped at 40. So if it is close to 30, 35, then the chances of poorer outcome are more, because in that case, the liver disease is too advanced. So we have to catch the bus in the right time. Okay.
So in between also, I'll emphasize once more, MELD score does not reflect the severity of nutrition. It is, or the functional status. So MELD is something which prognosticates a patient, but nutritionally we don't have, but we are. I'll tell you something, how we are connecting it. So this is just telling the nutrition status. Albumin is the best method to tell, and that is why it is the best marker of prognostication moving away from the MELD or in terms of nutrition. So next time, whenever you're looking for a patient or a liver patient, please look at the albumin levels. You will have an idea how will he do with intraoperatively or postoperatively. See this, you can see the graph. If preoperative albumin is higher side, the complications, postoperative complications are very less in low MELDer group. Can you see? The red ones is the higher complications. But in high MELD group, again, the albumin also doesn't work. So in a low MELDers, albumin is a good indicator whether the patient will do good or not. But again, like I said, high MELDers, albumin also will have no role. So now coming in terms of nutrition, sarcopenia, which you all know, is one of the measurements of nutritional and functional status of the patient with cirrhosis. And there are lots of studies which are undergoing. I don't know, are we doing any study at HN or somewhere else regarding the sarcopenia and the post-operative mortality in liver transplant patients?
Yeah, Jamrut must be knowing that.
So are we going abhi tak hua hai? Have we progressed? So how are we measuring the sarcopenia? Right.
Okay, so let's make it more interactive. So since all of you are here, so how to assess any patient's his nutritional status, especially in cirrhotics? So I think that's
Yeah. Yeah. So nutrition
then in that
status.
case, so it's-
To add on.
Yeah.
In the scientific strength which is done in the pre-transplant phase, and then I think we'll discuss that.
Yeah, we'll do it. Yes. So
there are various methods. One of them is
So I think we'll just skip these. Malnutrition is almost in 100%, shares 50 to 90, but all liver patients will be having nutrition issue. Then sarcopenia is loss of muscle and fat diminished from subvisceral tissues. It's adipopenia. Lack of awareness and conscious. Obviously, everybody needs to know about how important the nutrition is. For me, I'll tell you, this is fact, not because you guys are sitting here. If we take care of nutrition in liver patients, prognostication will be 100% if surgeon and the team, other critical care is taking care. So nutrition is that important. So once these studies come out, you will know that nothing can match nutrition status of the liver, especially. It, in fact, will go for all the transplants, but for liver more so, because metabolism and everything comes from the liver. So if you are able to optimize that part, nothing like it. So I think we should move forward in this direction and have something how to optimize a cirrhotic patient. That will really take us far ahead. I think nobody in the world right now knows how to exactly optimize it. There are nutrition, they put Riles tube, feed, but how to calculate how much to give, no studies have been done. So if we make some subgroups of some amount of calories, some of our proteins, how they're giving us the results, because in protein is also not easy to give in liver patients, then you might land up in having hepatic NCAF. But now studies are saying that no, it doesn't cause, but still there is gray area. We need to study and go ahead and do this. So I think this is food for thought for everyone. Whoever is involved in liver transplant, please go ahead and do such studies, because it will make life easier for us later on. 100%, please do that. Again, pathophysiology, I think we should not go into that. It should be influence. I just said, we were just talking about that. There's nothing close to nutrition which peaks on the prognostication. MELD is of no use, I believe. Good nutritional status, I would guarantee that patient will come out 100% if surgically done and post-op no infection. Even infection comes, if he has a good nutrition, he'll fight with the infection. So nutrition is related to everything, every part, in fact. Lung, the most important thing which I personally believe a patient comes out is when he has that capacity to get his lungs inflated. That is the strength of muscle of lungs, basically the respiratory muscles. That is directly related to your nutrition. No patient with a bad nutrition or bad respiratory strength will come out. There's 100% mortality if you are not able to inflate your lungs. Basal atelectasis, pneumonia, with immunosuppression, no patient will come out. So if it is deficient, 100% chances of mortality if you have a bad nutrition. So that is why you guys are the most important part of that. Realize that and let's work toward it, because we have a different job to do. Everybody has a different job. So if you guys just put in extra effort on finding out a good nutrition along with this expert, obviously, so we will definitely go a long way. So Meld, again, I think we should not go and guide, you will be good enough, probiotics, synbiotics. I think this is good enough, what I've spoken regarding Meld and this. Any questions I would love to take, and I would like to thank you for just listening to me. Thank you.
So how much time do we have for this session? No. So basically just, I wanted to summarize what Anil just said. So the topic was MELD and connection, what does that mean for dietitian? So basically, as we just discussed, MELD tells you the severity of the liver disease. Okay. Having said that, it doesn't take into accounts of nutritional status, which, as you said, is one of the poor prognostic factors. Okay. So there are various studies has been done, or there are ongoing studies which have shown that if you're nutritionally frail, if your nutritional status is poor, then the outcomes are poor. So there are some studies called as a MELD plus sodium, MELD sodium and frailty, MELD sodium and sarcopenia. Okay. So there are various ways by which we can calculate that, and that has been shown to impact the outcomes, not only in transplant, but even otherwise in pre-transplant, even during the intra-op period, and the overall outcome post-transplant. So as I said, MELD doesn't take into account nutritional status. So since you are going to have the entire session, but you should always make sure that this patient is adequately supplemented with the nutrition, because cirrhosis is a state where, because of various reasons, as the disease advances from compensated cirrhosis to decompensated cirrhosis, there can be lack of calories, especially it's a paradox, especially in cases of fatty liver or obesity, where they will be overweight at the one end, at the other end they will be malnourished or sarcopenic. So this is a strange or a different paradox where you have to calculate the need of the patient. And so the take home message will be that male doesn't take into account nutritional status. We have to calculate it, calorie requirement, we have to calculate the resting energy and then injury factor, and then we have to calculate it. I don't know which method do you follow, but ideally RFH, NPT is what we should follow. And then you can screen them and you divide them between mild, moderate, and severe, and accordingly you can give them calories. Calorie requirement is completely, very well known. In fact, malnourished, low calorie intake is associated with the worst outcome. So in any sick patient, the calorie intake should be 35 to 40 kilocalories. In fact, there have been talks of even going further. But as you go further, there are chances that this patient cannot tolerate the feed and bloating and diarrhea, the GI upset. So you have to find that balance. But as far as the calorie intake is concerned, it should be high calorie. Protein intake 1.2 to 1.5 grams per kg per day is indicated. Again, he mentioned something about encephalopathy. So earlier there were discussions or thought that too much of protein can precipitate hyperammonemia and can cause encephalopathy, but that is very wrong. Cirrhosis is a negative catabolic state where even in the grade 4 encephalopathy, protein restriction is not warranted, because if you restrict protein, there will be more and more catabolism that will further worsen hyperammonemia. So that is not accepted even in the full-blown cirrhotics with grade 4 encephalopathy, no restriction of protein. And the meals should be planned in such a way that it should be small, frequent meals. And the key parameter here should be late evening snacks. So that is something that we should follow. So before going to bed, they should eat something, and after getting up, they should eat. If they could follow this, then I think they could able to achieve at least bare minimum what is required. I think.
Yeah,
that
and
we should
do, and yeah, I'll first ask question, then I'll finish. Yeah.
What it is based on the severity of
MELD score.
the MELD score.
Yeah.
So how do they decide, and wouldn't the very severe scores have poor prognosis?
Yes, but that's why they require liver early, no? So prognosis would be, you don't care about the prognosis because you need how urgent you need. That is why they would require it. Here, whoever registers first is in the list and he gets it. Except for the super urgent, which is different. In acute liver failures, you have the option of getting a liver if you're registered as a super urgent. Rest, whoever comes first gets it. There, whoever MELD score is higher, like he said, whoever is higher has a bad liver. So he needs earlier than rather than the other. He has time. This guy at 40 doesn't have time. That's why. So, and continuing with the MELD, now I'll connect MELD. So itna bol diya, no connection. So there is a MELD coming out with the body composition, MELD BC. So hopefully we will have a MELD with body composition, because the nutrition is most important thing. We will be soon having that MELD. So yes, so we have a connection, Eileen. Good job. Thank you.
Can I have
Please go ahead.
I think I'm audible.
Yeah.
Because we're just mentioning body composition analysis as well as MELD. I wanted to know what parameters in body composition analysis will be of importance.
That I think I'll leave it to Kalal. I have no idea.
So this is out of syllabus question, by the way.
So let it be
No.
open
So body
discussion.
composition analysis, phase angle, alpha angle is something that we should, we should look at. If it is less than 4.5, it indicates severe malnutrition. It has to be more than that. That is one thing that you can utilize. Then there are various other parameters of body composition analysis that can be utilized, like visceral fat, total fat, free water, body water, protein that can be utilized. So yeah, phase angle is something that has been shown, to be a surrogate marker for malnutrition, though it is not validated in most of the studies, but it is one of the very good marker and easily available.
But studies abroad for any other also talk of phase angle. Yes.
The phase angle, as I said, it is not validated. So yeah, so cutoffs are 4.5. In fact, in my study, I have utilized it and it does correlate well with the, so it's a good parameters to be used. And as I said, it's easily available.
And there are people working for it. So let's hope that it comes out soon, because right now we are all having studies on sarcopenia only, sarcopenia and that. So this would be something new. And recently, that's why I said, good job. This is going ahead, and hopefully 6 months, 1 year, we'll have a meld with body composition. Thank you.
Yeah, request Dr. Kalal and Dr. Anil Singh to stay on, because I would like to felicitate and thank you for coming and giving us so much knowledge, interactive session, and so many more ideas for new research and new aspects coming in. May I invite Shiva? Shiva is Vice President at the IAPN National Chapter. So, thank you, Dr. Kalal. Can we have a picture of both of you together with Shiva? One picture with both of you. Thank you so much. We move on to our next talk, which is very interesting. And for that, we have Varsha. Varsha Gore is Chief Dietitian at Apollo Hospital, Navi Mumbai. A lot of experience with transplant patients. And she is our chairperson. So she's going to conduct the session. And thank you, Varsha, for coming. Over on to you.
Thank you, Eileen. I think it's a great job you have done to get all the specialists, and we look forward for more transplant related nutrition. And I'm indeed very happy to be here because our speaker, my dear friend, and who is so hardworking, passionate, dedicated. She really rocks. Zamrut Patel. I think she doesn't need introduction, but it is more of a pleasure to introduce about her. My words are really falling short.
Let me start.
And for the convenience, I want to sit as an audience and then come back over here, and then we'll take a discussion.
Sure. So thank you, IIPN, for having me here. My passion for renal nutrition has driven me to transplants. And when I started working on, first I started working on renal transplants, and today I actually am working with all forms of transplants. When I joined Global, the main purpose of me to come to an hospital setup was to learn more transplant. And believe me, till date, I am learning. Whatever I am presenting to you is based on whatever I have learned in my journey of these 2 decades on transplants. First we didn't have transplant program in our city, and I used to get patients who used to get transplant done abroad. And it was not that in those acute phases I would see. And Dr. Chetan is here, and I remember every day when he was with us at Global, every day morning, he would enter one room and then he would say, please follow. He would come out and he would say, please go, you're needed. So I used to tell him that everywhere you're making me follow you. But indeed, it is important to understand that nutrition is very important in these people. Now, if you see the topic that Eileen has given me is SPF. 3 important nutrients that I have been working around, whether you talk of any disease. For me, salt, protein, fluid. Okay, so these are 3 somethings which are very important. But apart from that, what you need to understand in these patients of liver is that calories are very important. How you get those calories is equally important. These are some things that either you add or you have to delete. But calorie is something that you need to keep very constant in this population. And why do you need to do so? Because of the burden of malnutrition. You've heard of MELD. Okay, so when they used to calculate the MELD score, I would just see the MELD score to see कि 15 के ऊपर कौन है. Whoever was beyond 15 definitely needed an intense counseling. Okay. Why? Because definitely their appetites were poor. Definitely their nutritional status was poor. So when he was saying that MELD is not related to nutritional status, I wanted to tell him, no, for nutritionists, it's important to know the MELD score. Then we need to work harder. We know who would need more intense counseling. So burden of malnutrition is there. And actually, if you see in liver patients, we normally divide them as alcoholic and non-alcoholic, but malnutrition is present in both. Okay. If we say that they are NASH, because of fatty liver, they have end stage cirrhotic, it is not so. Both the groups have equal amount of malnutrition. So whether you're dealing with NASH or you're dealing with an alcoholic liver disease, you need to concentrate on the nutrition. That's very important for us. Now, we all as nutritionists know, I don't have to get into the depth of this. They have anorexia, they have nausea, vomiting, and I always say we are responsible. Why I say we are responsible? Because we talk of the don'ts. Most important nutrient that we restrict in this population, salt and sodium. When you are doing that, the diet becomes highly unpalatable. So it's mostly us. We have to work closely with these people so that we can improve their nutritional status by giving them adequate amount of edible food, palatable food. That's important. Okay. So our work is not to stop food. Our work is to add food. And definitely these are the most common reasons why they don't eat. And nobody likes to go to the hospital. Nobody likes even to come to see us, frankly. These patients, they'll ask, paper de do bahar. From my door, they stand and they knock and they tell me, diet paper de do aap bahar. I said, no, you come and sit, tell me what you want. I will modify and give you. So that is the level of interaction that you need to have with these patients if you want them to have better nutritional status. I will not say good, I will say better. Okay. So again, the disease is responsible. I don't want to get into the metabolism of this, but the disease is responsible because they have ascites. You're restricting their salt. They have a feeling of fullness. They have nausea. There are waste products in the system. They are not able to eat well. Okay. And you need to understand that last point, accelerated state of starvation. When somebody starves for 3 days, what symptoms you see? No, in these people, you see that symptoms when they starve for 10 to 12 hours. And that is what when Dr. Chetan was saying, early morning and at bedtime. These are two important meals that need to be focused in this population. Okay, that's very important. Even post-transplant, when they are undergone the transplant, even then you need to concentrate on these 2 meals. When you see these symptoms, what is utilized? Like liver doesn't have the glycogen store. Your proteins and fats are getting metabolized, and that is making them still weaker. So abnormal substrate utilization causes further malnutrition in this population, and that is why you need to give adequate calorie, adequate protein. Okay. And of course, malnutrition and sarcopenia, this is a multifactorial thing. I don't need to emphasize on this. There are many reasons that can cause this. And we really need to give good nutrition. Based on the stage of liver disease, you need to give them the nutrition. Okay. So when they are only cirrhotics, they come with a bilirubin of just 1 or 2. Maybe they don't have any other system. They don't have ascites. They don't have a GI bleed. They never had an NSF, or they do not have any other form of cancer. Probably they are better. But once all these things keep adding to them, nutrition needs to be keep changing for them. That's very important. So again, this is just to show you the hierarchy, how the nutrients are used. Liver and muscle glycogen is used in the early stages, then adipose tissue and muscle. I was talking of starvation in them. And then later stages, when organs are being utilized. And some of these patients, when you just see bone and skin. And they'll come with a very protruding abdomen. And when we'll do, I'm sorry, but most of the hospitals today, when we do height, weight, BMI. And when you see their BMI will be obesity grade 1, 2, 3. So BMI is not a good marker for these people to be used. And again, there is a lot of, we are going to have a lot of discussion on assessment. So I have not put a lot of it, But yes, the goals are to provide adequate energy, to keep person in nitrogen balance, and to prevent rise of ammonia. So the type of protein that you pick is very important in this population. That's very important. And again, when you do that, you give them the right nutrition, the quality of life is better. When they eat well, they are feeling better, then they want to listen to you. Otherwise, they don't want to listen to you. So this is just to show, I'm not going to get into assessment, but I just thought, let me show you the way we are doing assessment in our hospital. My slides are moving, but slides here are moving. Okay, so we normally do these parameters. So you have the RFH that we are using for doing the assessment in our population. Why is this not getting coordinated? Okay. Can you go ahead? You're operating from there. Go ahead. 2 slides, you go ahead. Next, yeah. So now coming to actual calorie and protein. This is just basics that we start our patients with when we are doing their calorie requirement. We take them as compensated or decompensated. Previous slide, please. Yeah. So when you see a liver patient who's compensated, probably you can give him normal nutrition, but you do need to do an assessment, and you do this assessment regularly. When you do the assessment regularly, only then you can pick if there is any deficiency or they are going further for malnutrition. So what you need to do is calories adequate. Now, if you see 35 to 40 kilocalories is our target, how much are we able to achieve? Nutritionist, hospital nutritionist, OPD, I will not ask, OPD is still better, I would say. IP, you know what is our patient's intake? Half of this. 15 to 20 kilocalories is what they are eating. So we have a big target to achieve. Carbohydrates, definitely. In fact, many a times, even in diabetics, you know what we do? We tell our doctors, we'll take care of the calories, you take care of the sugars. Only then we are able to feed our population. Okay, otherwise it's difficult. Again, fat, no restriction except when there is some form of intolerance, and most of the time you will find that whatever diet prescription we are writing at the hospital, we are using normal oil, but we are also giving MCT to our patients. The reason is because it is to provide that calories that you need. Okay. Coming to proteins, Dr. Kalal did mention that the protein requirement is 1.2 to 1.5. You need to give higher protein content. You need to check what supplements you're using. You need to have supplements which give branch chain amino acids. And today, fortunately, we have ample of them. You don't have to worry. You know, if the patient has a problem with the flavor, different flavors with branch chain amino acids are also available. So you can pick those, you can use it, and you can see that your patient is eating better. Even if the patient is having NSAIDs, you don't have to drop the protein drastically now. You can keep it to normal, that is about 1 to 1.2. Yes, in a few cases, we have dropped protein to 0.8 also, but they are very limited cases. But definitely you need to give good quality protein, giving adequate amount of branch chain amino acids. I'm not going to get into this, but what I would focus is whey protein. If you see that, again, my slide has not changed. Go to the next slide. Yeah. Okay. So branch chain amino acids are oxidized to produce energy for muscle and other organ. It stimulates protein synthesis, and that is why we are focusing on branch chain amino acids, and it reduces skeletal muscle catabolism. So definitely don't hesitate. See, we are talking of nutrition. Okay. Many a times only by diet we will not be able to achieve our targets. So we should not hesitate to use oral nutritional supplementation. Right? Oral, you first give your diet. You're not able to reach your targets, use an ONS. If you're not able to reach your target, talk to your doctor. Think of tube feed, additional. So give the tube feed in the hours where the patient is not eating, right? And sometimes if the patient is not ready to eat, not ready to take anything, then only on enteral nutrition also we have to depend on times. So if you see the quality-wise, whey is better. And there are, again, I'm talking again, today you have products in the market which will definitely give you this quality of protein. You don't have to think back. Second important thing, salt. Very difficult, because When it is compensated, it's still better. You're giving them almost near normal salt, okay, near normal sodium. When it is decompensated, you have to bring it down. And that is the phase, because of the extensive ascites these people have, because of the lot of nausea and vomiting they have. When you bring down the sodium and the salt, the diet becomes highly unpalatable. And there is our role. See, fluid over here may not be that strict a restriction. It's not like the renal cases. Of course, when HRS is there, it's a different scenario in them. But in general, most of the time, fluid restriction is not very strict in this population. But yes, there are a few cases which would not respond to your diuretics because they are on diuretics. Then probably the fluid restrictions doctors will ask us to do. Otherwise, fluid mostly we don't restrict that much. But salt restriction is something that is very important. And why are we talking of this salt? Because sodium and salt makes the diet highly unpalatable. We all agree with this, right? So as nutritionists, our job, what you combine, how you combine is up to you. Okay, but one thing that you need to remember when you're using these products, which are today available freely in the market, and we've been using it in our kitchen for long, the kokum, the tamarind, today you get a variety which is coated with salt. So when you're buying, asking your patients to buy these products, they need to buy the salt-free variants. Okay, that's very important because we had this, that's why I'm talking over here. We had where we just gave the sheet, we were in a hurry, and the patient brought, and actually his salt intake increased rather than reducing, and then we were hunting where it came from. So that's how we picked it, that when we are asking them to restrict, they need to see what variants they are buying. So it's very important for us nutritionists to talk about these small things to our patient, what they are buying, the grocery that they buy, how do they buy. Like somebody we placed for 2 days on a salt-free diet, and when we did a 24 hours urinary assessment, he still had around 6 grams of salt. How? So when we actually evaluated his diet pattern and we saw the masalas that he was using, they, get a masala from a lady who makes it once in a year and gives them. So when she's drying those spices, she's putting salt and she's drying it and then she's powdering it and giving. So the patient never knew that indirectly that salt was coming. So these are the small things that we need to be talking to our patients, Again, this is just to have a summary of whatever I spoke. Adequate amount of carbohydrate, adequate amount of proteins, adequate amount of fat. Salt needs to be restricted. But again, having said that, we need to see the ascites level, what diuretics compensated, decompensated, and then talk of salt restriction for this population. Again, nocturnal feeding that we just discussed, very important. And ideally, if you ask me very honestly, early morning and bedtime patients are not ready to eat. So the best friend for us is our ONS at that time. Balanced nutrition, what calorie protein you need to calculate, whatever may be the fluid requirement, you can calculate and give your nutrition in that form early morning and at bedtime. That's we have been practicing for all our patients. So that's very important. Again, this is a 3-meal pattern, which is recommended. 3 major meals and 3 small meals. This is around what we have been practicing. And as I've told you, we go for oral, we go for enteral, parenteral, not much. But yes, if they are not eating, we don't hesitate to tell our doctors, please put a tube. We will feed via the tube. So these are the best guidelines if somebody wants to read EASL guidelines for nutritional management of cirrhotic patients. They've just come. I think mine is 2019, but something has come in. I think this year also something has come up. Some minor revisions will be there. So these guidelines clearly indicate that a multidisciplinary team approach is needed for this population. That's what I want to highlight. Otherwise, all the factors that I spoke to you are there. Enteral nutrition, lifestyle modification, and the diet needs to be tailor-made for the person. You cannot have one print sheet which we keep using it for all our patients. That's important. Again, when a person undergoes transplant, I've just touched upon 1 or 2 slides on that. Normally, we use a protein calculation of about 1.5 grams per kilogram body weight and adequate amount of calories. That is for normal, what we use, 35 kilocalories. But here also, we try and feed them early morning and at bedtime, because you need to understand that they were malnourished. Now they've got a new organ, they've got the transplant done, but the stores needs to be built back. So that also nutrition plays a very important role. So during post-transplant, after transplant, you really need to focus again, counsel. Fortunately, here the patient is in-house with us for 2 weeks. So every day, twice in a day, we counsel the patient and the relatives here. Okay, so that's how we achieve our targets for getting their nutritional status. And again, as I have to already emphasize, can you go to the next slide, please? I've already emphasized, first we try oral, then we try oral and supplements. If that doesn't work, we request for a tube. And if nothing works, then only tube feed. So just to summarize, you need to feed your patients very well. You need to concentrate on branch-chain amino acid supplementation for cirrhotic patients. Food should be palatable. That's very important for our population. And a multidisciplinary team approach is very important. So thank you. This is what I wanted to share with you based on my experience.
Thank you, Zamrud. I think claps are saying lots, as I mentioned, and I'm very happy that I introduce you as a good teacher and a practitioner, and that is all what speaks. While this topic was designed, one more F came to my mind, and I think anyone get any guesses? Fiber. Fiber would be also essential.
Yes.
Because at a point you're restricting certain things.
Yes.
So you're looking at the sugar management.
Correct.
So that also needs to be looked at. And
Yes.
we definitely look at, but it is slightly forgotten nutrient because it doesn't provide with the calories. But when you're looking at the gut functioning, fiber has an essential role. I had a query regarding the supplementation because you did give a good response that, we don't know what to feed at night or early morning. Supplements work best. But we have a lot of students and they would like to know a little bit more about what type of supplement comes to your mind when you're doing a overnight kind of feeding, because you have to manage the hypoglycemia. So how do you practice?
So as I've told you, I normally give an ONS in water or in milk, depending upon my patient's tolerance. And early morning also I use that. Sometimes if we find that their dinners are lighter, then we give them a small snack. So dinner, post that a small snack, and then an ONS. So that's how we practice. And again, I think that today you have these biscuits available. You have these protein bars available, which are low sodium, which are available. And again, you can use those because some people may not like to have that liquid. So we use the biscuits and the protein bars.
Very good, because that's a boon. And they get fatigued with the taste, flavor, liquid, sometimes that is the restriction. So now you have options, how you can add.
Actually, I'll tell you one, if you see our patients, when you enter their room, they have around 6 tins of supplements because of the flavor. Very honest. They'll have 3 to 4 variety of protein bars and 3 to 4 variety of biscuits in the room. Okay, because even you think yourself, if I have to have the same thing again and again, taste fatigue is something that again may drop their intake. So what we want is they should eat well. So we actually recommend that today. Get different flavors so that they can eat better.
In fact, this disket thing, I had learned from Zamrud only because we talk to each other very often when we have any cases, patients shifted from this hospital to other pediatric or any other specialty. So we do have an interaction and I wanted her to highlight this particular point.
Yes, Chetan, you wanted to add something. Yes. There is a paper on giving at bedtime corn. Yeah. Manjap. Yes. Now, earlier we didn't get roasted chana without salt. Now you get a variety which is available in the market without salt.
And what options you said, right? Because they work as a good source of energy as well as fiber. Everything is perfect for the management.
Yes. Yes. Yes.
Palatable also.
Yeah.
Easily available. Well, I think we can have more such discussion when, the other sessions go on.
Thank you. Thank you.
Please stay on, Zamrud and Varsha. May I invite Shilpa? Shilpa Verma is National IAPAN NEC Vice President and also the Program Director for SPEN ELL. So please felicitate Zamrud and Varsha. In fact, I'm very thankful to Zamrud that she was able to come today. Ideally, my talk on assessment would have been before her talk, but I knew that I wanted only her to speak, and she's leaving for Delhi right now. So I allowed her to speak before me, because you must be wondering, what sense does this make? You're speaking of MNT before the assessments, but I'm going to talk of assessments after the MNT. Thank you, Zamrut, for joining in. Thank you, Varsha. So let's come to our next session. And our next session is going to be something which I would like to tell all of you. And to most of you here, you must be really wondering what I'm going to talk about, the story of ANS. And now ANS, to tell most of you, is the Academy of Nutritional Sciences. The story began like this in 2020, when there was pandemic and everything shut down. Okay, so we in our hospital, we have an academic wing where we take all interns, whether it's doctors, physiotherapists, dietitians, everybody comes under the academic wing, and teaching goes on. We are very happy. And one fine day, teaching just stops. And it was like in 2020, we started innovating, and we started looking out for other resources, because you ask the plant not to grow, would it not grow? It will still grow. What did we feel when we were asked to just shut our colleges, shut our schools, shut our education? But did growth stop? Growth did not stop. And similarly for us, this is the story and the birth of the Academy of Nutritional Sciences. And that's when the birth of this happened. So let me give you a quick brief of what we do at the Academy. So the e-learning happens. We have live sessions with dietitians. We have continuous learning. We also have collaborations. We have patient education, and something that's very close to my heart, the research wing. I'll explain to you all a little more in detail about that. Now, what do? We enhance the knowledge for practicing dietitians. We have trained in these 3 years many dietitians, over 500 dietitians on various topics. It could be liver, diabetes education, something that came from the dietitians itself, that we want something on soft skills for dietitians, because we are expert clinicians, we are expert in our work, but somewhere down the line we need to understand other aspects of speaking to patient, counseling, talking to patients. So that's where the soft skills came up. Then we had something like brushing up basics, because we had many even college students who were undergraduates wanted some refreshers in their vacation. We have a very, last year, in fact, this getting ready for competitive exams, from our 9 students that we had 7 who actually passed the exams, and we are very proud of them. They are here, and they are also listening to me. So some who are in Mumbai, they are here with us, and some are listening to us online. So they could crack those difficult exams. Also, we have a lot of teachers who come to us and tell us that they want to integrate their textbook knowledge with what is happening on the ground reality inside the hospitals. And we have collaboration with many teachers who have come to us, like from Delhi, even Calcutta and Sri Lanka. They want to learn more about things that happen, which is in practical. So things like what's there in the liver transplant, or what are the other clinical guidelines that are come, the latest guidelines. So all those things are explained to them. Then we have advanced programs for clinical nutritionists, including the pediatric parenteral nutrition, bariatric, nutrigenetics, ketogenic diets, and many more. We have a patient wing. Now, here the patients come to us, they speak to us, they talk to us, take a diet, they take 2-3 counseling, but sometimes their questions are not answered because they are inquisitive. They want to know more. Like recently there was so much of hue and cry of erythroid, right, which was there in stevia. So patients came back to us, can we use erythroid? What is it? Why does stevia have erythroid? So then we had to explain to them What is the concept? Because they say it's advertised as stevia, but we are actually eating erythritol. So those questions had to be answered by us, which may not happen in a one-to-one session. And then we need to connect with them on a different ground. So whether it is sweeteners, any myths, facts, women issues, which fat to use, which oil to use, all those questions are answered in a patient wing. Then we have people who have finished their treatments, cancer treatment. They've finished with surgery, chemo, radiation, everything. And they still want to connect with us, and they want to connect with other people who are of the same category. So we have support groups, whether it is cancer, renal, transplant, or bariatrics, or any other support group. We also have collaborations. So last 1.5 years, we have been having collaboration with the NIFTEM, that is the National Institute of Food Technology, Entrepreneurship and Management, and the KNRC, that is the Kerala Nutrition Research Center, where we have been training around 400 dietitians working for the Kerala government. So that's kind of collaborations we have. Now, this is Re-Explore. What is Re-Explore? First of all, I would like to thank the ICNC 2023 last year for giving me the award. That is the state level award on my research. And that research I owe to Explore. So people, after I got the award, everybody started asking me there itself in the hall that you are a hospital dietitian. What do you do in research that you had to get literally a state level award? I said, yes, I did get a state level award, and ICNC just didn't give me like this award for state level because they saw something in it. And what they saw was in this Re-Explore. I'll just give you a small glimpse of it. For that, I will invite my specialist, Vedika Priyanka Lula, where she'll give you a small glimpse of what she does in the Re-Explore. Priyanka, come in.
Thank you for the introduction, ma'am. So at Re-Explore, we have done many studies, but one of my favorite is the Nutritional Stewardship Program. It's a study that is very close to my heart. We have designed a special study with the intensivist. Nutritional stewardship, actually the stewardship means supervision. So we are doing a nutrition supervision over here. We have won many awards at the ICNC, which ma'am mentioned, at the ICCM Criticare in Indore, where we were selected as the top 20 in the top 20 studies. And this is a conference in which all intensivists were there. And also a quality award, the Healthcare Quality Award, Quimpro, which happened at Hinduja Hospital. So we are very happy for that. So what we actually do in this program. Okay, so this is a study where we do in the critical care unit. So we assess the patients when they get admitted in the ICU. We use the NRS tool. We establish a nutrition target depending on the condition of the patient, the fluid restriction, the hemodynamics. Intervention is planned. And then we do a very, very close monitoring of this nutrition delivery, okay, wherein we have integrated digital systems in that. And we also take the help of the nursing, and we identify the barriers of feeding. So I'll come in the next slide a little bit of detail in that, which are the type of barriers that we see. Those are very typical barriers in which we have a defined plan for them. Okay, and then we calculate the nutrition delivery and obtain the energy and protein deficit. So this is actually a cumulative deficit that starts from day 3 of ICU admission, and then we follow up the patients very closely. And then depending on how much deficit they have attained, we do a implementation. We implement a catch-up feeding and different types of catching up actually. And once the patient, actually what studies say, when the patient enters more than 10,000 calorie deficit, that's when the mortality rate increases. So then we have also measured the deficits with the outcome, like the length of stay in ICU, mortality, and various others parameters like ventilator stay. So here, what we do, these are the feeding barriers that we have identified, and we have a defined plan for them. Okay, so for procedural fasting, the patient is NBM for maybe pleural tapping or some procedure that happens. So we do a catch-up match-up feeding similar to the PEP-up, wherein we compensate the feeds that they have skipped to the next feeding that we step up. Then for fluid restriction, then we do the hypercalorifics, we do a lot of TPN, a lot of supplemental parenteral nutrition, wherein we do the intralipids and the albumin to see what are we lacking in and accordingly supplement. For GI intolerances, again, parenteral nutrition. And for lack of awareness in the ICU, we have conducted many CMNEs, many trainings to the nursing, to the doctors, and we have actually seen a very good result in that, wherein the doctors themselves start, thinking about nutrition, and this patient shouldn't enter in deficit. Otherwise, we go to the rescue then and we call them up and all of that. So that's how we do. And we are also developing a nutrition research app, which is in the pipeline, in which everything is embedded. On a click, we can obtain a lot of data and analyze it. So it's ready for analysis. So this is coming up. And we invite you to actually expand the study to make it a multi-centric study. So whoever is interested, then we can speak about the details about this. And at Re-Explore, basically, we do a practical guidelines, the critical analysis, help you with the critical analysis, help in scientific writing, how to digitalize and simplify these processes, how to do the data collection in a simplified manner. So that's how it is. Thank you so much.
Thank you, Vedika. That sounds so interesting. So please do get in touch with her if you want to have we want to have a multi-centric study with other hospitals also. So we can have better data. Now I come to a little bit of the assessments. So we talk about liver assessments, and to start with, we heard a lot also by both the doctors, Varsha as well as Amrut, did speak to us on liver assessments. And I'm going to give you a little detailed view of it. My topic today is Jigar ka tukda. What does Jigar mean? Jigar ka tukda means? For who do you call Jigar ka tukda? Loved one. So what does it mean? It means that we have to love our liver. Okay. So it literally means jigar ka tukda, that is the loved one. And today we are going to talk about something in nutrition which is a little beyond nutritional assessments. So now, nutrition in liver transplant. Are we doing too little or are we doing too much? Now, frankly, in our hospital, we really do a lot for our patients, and doing a lot really means a lot, because the outcome that we see for our patients is really awesome and good. And we can actually make out that if we look at the patient right from the beginning, we will have a good outcome. So one question which I would ask, which assessment tool would you be using for the liver assessment? And most of us will say the subjective global assessment, which is the right answer. And it is correct that we do the subjective global assessment. But still, we go a little beyond the subjective global assessment, and we do something called the Royal Free Hospital Nutrition Prioritizing Tool, or the RFH-NPT tool. This is an assessment tool. This has also been recommended by the SPEN 2020. Now, what is in that in SGA that we need to do an RFH-NPT tool, because historically in an SGA, what do we see? We see the height, weight, dietary changes, loss of weight. We also do some physical examination, subcutaneous fat, muscle wasting, etc. And we divided the patients into 3 categories, A, B, or C. Now, based on these categories, we understand that although this is a very easy, simple tool to administer, and we have a fair, good observer reproducibility, it correlates preoperatively with patients without cirrhosis. Okay, so what Dr. Anil just asked me, do you do something for sarcopenia? And yes, this is something where we have to go beyond, because we have to identify sarcopenia, we have to identify fluid retention, and we have to identify peripheral edema. Now, these 3 things have to be identified beyond the SG, and therefore the RFH-NPT comes in play. Now, what is this RFH-NPT tool? This is a tool that's used for malnutrition for liver patients. So in a head-to-head comparison of the RFH-NPT tool, it was found out that it was more sensitive to the NRS 2002. And therefore, this tool was taken into consideration. And even SPEN said that you should be using this tool instead of the NRS or the SGA. So what does this tool include? Now, in this tool, you identify 2 things. You divide the patient into 2 categories. One category is where you have the alcoholic hepatitis patient, and the second category is the non-alcoholic hepatitis patients. Now, alcoholic hepatitis patients with a tube feed automatically go in a high risk. So that's finished. But a non-alcoholic hepatitis patient who does not have a fluid, who does not have a tube feed, we identify and look out for certain things called fluid, that is fluid overload. And if they have a fluid overload, and if they have an intake problem, then we kind of categorize them. And those who do not have a fluid overload, those who do not have any other issues, then automatically for them just the NRS or SGA is more than enough. How does this RFH-NPT tool look? It looks something like this, where we have step 1 to identify cirrhosis, hepatitis, alcoholic or non-alcoholic. Then we have step 2, where we look at the fluid overload. We score it accordingly. Then we also ask questions like, does the fluid overload interfere with the patient's ability to eat? Does the fluid overload also interfere with the patient's reduced weight? And does it interfere? And since how long is it happening? Whether the patient is on diuretics or not. And in the step 3, we identify the score. So if it's a 0 score, we know how to react with the patient. And if the score is somewhere between 2 and 6, we know how aggressive we have to get with our nutrition. Now, how do you find fluid accumulation? Because it's not very easy to understand. Yes, you'll do pitting, edema, you'll find certain things, but even if you do with an ultrasound, you will find mild fluid ascites, even up to 2 kgs to 14 kgs. So much of weight difference can happen with the fluid accumulation. So your entire weight get distorted, which is the basis of counting your calories and proteins and fats. So if you get the wrong weight in the first place, how will your calculations work in the second place? So that is something. Then we do something called a subjective override. Now, what is this subjective override? Subjective override is where you look at the BMI, you look at the MAMC, and you look at the dietary adequacy. In the subjective override, you look at all these 3 and you score the patient. Now, what do? Next, we have finished the RFH-NPT. We do something more called the CONUT score. Now, this CONUT score, if you remember, Dr. Anil was saying that we look at the albumin. Okay. Now, what is it? This CONUT score is a controlling nutritional status score. This CONUT score will also take into consideration albumin, lymphocyte, and cholesterol. Why don't we take only albumin? Why do we take lymphocyte and cholesterol also? When patients are cirrhotic or they already have a low albumin level, they are on IV albumin. So if I take only albumin, I may get a wrong scoring, thinking that, oh, this patient is well nourished. but there's IV albumin also. So in that case, we have to go a little more beyond to understand the lymphocyte and cholesterol count. So we have a scoring system where it's like a table where you have normal, light, moderate, and severe, and you do the serum albumin score, you do the lymphocyte score, which will give you an immunity aspect, and you do the total cholesterol score. And you get the score. Suppose you get the Conant score of 9, then you know where your patient actually lies. Correlation with body composition testing is very, very important. We have very good body composition machines in our hospital where we do a detailed body composition. We also use DEXA, MRI, CT, and all the other body composition techniques that need to be done for a patient. We do everything, and then we correlate it with the other scores. So this is how we do. We correlate each and every score, and we get a kind of a total score. So if you look at the SGA, you look at the RFH NPT, you look the subjective override, you look at the nutritional intake of the patient, and you look at the Conant score. This will give you an exact bird eye view of where your patient actually lies. This is something that we don't do. The doctor does. That is the CTP score, that's the child Turcotte-Purg score, where they also look at prothrombin time, they look at ascites, which we cannot look at. Basically, ascites, flu tapping, all those things are done by the doctors, but we have to correlate. As he said, we correlate the MELD and we correlate the CTP scores. So this is where talking about assessments, it does not end there. There are a lot of things, but these are the main core of assessments. If you look at the guidelines, 2020 guidelines, there are some 85 recommendations, 17 statements, which I think now Shiva is also going to talk about a little bit about where we lie for guidelines. But guidelines will give you an idea of what you need to do, but how you have to do is in your hands. In summary, I would say that a dietitian needs to know pre-transplant workup, understanding the NPT, DEXA concepts of the MTT approach, and the post-rehab and post-transplant MNT. Now, I would like to make you all think something. Some of you all may think that anyway, we don't have transplants in our hospitals. What does it matter? But is the transplant a beginning or the end of the treatment? Transplant is not the end, nor it is the beginning. The beginning starts with you, actually. When the patients come to you with a fatty liver grade 1, that's the beginning. And if you do not catch the patient at the beginning, you have already lost half your battle. So what you need to do is look at the beginning, not the end. So when you find, everybody in the executive health checkups will find a patient who has a fatty liver. How many of us also may be having? Correct? Yes. So that is where, so liver transplant is not the end. Actually, it is in the center, somewhere in between, because we need to know of the ALF, we need to know ASH, we need to know NASH, we need to know cirrhosis, and we need to know liver transplant. So liver is very huge to actually do. Transplant is a small portion of it. I'm having another session which is called Chef the Oeuvre, which is an upcoming event which is going to happen. It's actually a master class in nutrition care for clinical dietitians. We are having an in-person physical this thing on the 20th of May in Mumbai. And if you are not from Mumbai and you still want to attend this, we have an online, which is on the date of 2nd June. If you want to register, Prajakta is there outside. You can tell her that you are interested in this. She will give you a guideline where we will be teaching about micronutrient supplementation consideration for protein, carbohydrate, lipid, as well as branch chain amino acids, nutritional support during and immediate post-liver transplant, both in the short-term and the long-term phase. We'll be also talking about ERAS protocol. Pooja and I were having a good conversation of ERAS protocol the other day. Special consideration for pediatrics liver transplants, also osteodystrophy, symbiotics, rehabilitation program, liver gut brain axis. So thank you very much for hearing. I would be happy to take questions. but I think we can reserve the questions for our MDT round. MDT is a very important round. That's a multidisciplinary team round. And the reason why we kept this round is because as Zamrud also said, that is one aspect which has come up in the newer guidelines. And this MDT round is so important that I will give you an example that we have an MDT round before every liver transplant, and the dietitian is also asked, and it is recorded, it's a recorded session. And when it comes to the dietitian, she is asked one question: is your patient ready nutritionally for the transplant? And if she says that give me 1 week or 2 weeks more to make the patient nutritionally ready for the transplant does not happen then. The time is given, because if the patient is not ready for the transplant, the patient's outcome will be very, very poor. So we build up the albumin, we build up the other aspects, and we are the same. So my MDT dietitians are there behind laughing, but that's the fact. Yes, so can we have our next round? That is our MDT round. May I invite our MDT specialist on to the dais? May I invite Shiva, Shilpa, Nazneen, Cecilia? Okay. Yeah. Ashni, have I left out anybody? No? Okay. Okay, so with a very quick introduction, or can you introduce yourselves very quickly? Yeah? Start with Cecilia.
Because you can hear me. I'm Cecilia Checha. I head the Department of Psychology at Nanavati College, and it's an absolute pleasure to be here. I look forward to this very interesting MDT. Thank you for having me.
Myself, I'm from Curtain Raiser Hospital, and I don't think I should spend time on the
I am Nazneen Hussain. I own my own internal venture called Freedom.
Request you to use the mic because we are also online, and our viewers would like to hear you all clearly. Okay, so let's start and begin. Actually, the MDT is a multidisciplinary team which also has more people than this. So we have a social worker. Unfortunately, I wasn't able to invite the social worker, and we also have physiotherapist, and we have other people. But going forward, let me start with Shilpa. Shilpa, what is this impact of 6-month rule for a liver transplant?
To explain about the 6-month rule, first I acknowledge you for the way you presented, and you did mention one thing very pragmatically, that maybe so in our center we are not a liver transplant center, but as you said, somewhere that chronic liver disease patients who may be we may be the first people whom they see, and that's where the onus of their further treatment probably lies on us. It starts with us, and that is very true. So when we talk of this 6-month rule, if we look back in time, this started somewhere in the 1983s, where probably liver transplant for alcoholic diseases was not very rampant. And it started with an observational study of only 11 candidates, if I'm not mistaken. And when they saw the pros and cons of somebody who has liver disease because of alcohol, and the ones who have this requirement for a liver transplant other than alcoholic liver disease. And we know organ donation is not very easily available. We know it is not very I won't say advertised, but not much awareness is there, not much is spoken about, and not maybe as a culture, maybe whatever the reason, we are also, even if we know how many of us have pledged our organs, right? So not a lot of people are forthcoming about it. So then that debate started. So actually, this is a debatable question with two thought processes and two lines of practices, where they felt that somebody who does not have an alcohol related issue can be a better candidate. When I was thinking about it, reading about it, I think we all have taken the Hippocrates oath, right? Of an indiscriminate choice and access to whatever care that patient could have. And if we think on those terms, this 6 month also came up very, very, so there is no actual guidelines to say it has to be 6 months. If we look at psychological aspects, it is not that if 6 months somebody has abstains from alcohol, he would not again pick up the habit again. So having said that, in the, say, around 2014s and probably now, most of the European and the American associations have given up on this 6 month rule, but prudent patient selection is important. A chronic alcoholic or even a recent alcoholic, which can give an impact to the liver. We are talking of post-transplant issues where there can be a graft rejection, there can be other metabolic consequences if the patient again goes back into his drinking habits. So I think that rule comes up from there. But as you said, if there is a multidisciplinary team, and which you just, like, I had goosebumps seeing your research, I had goosebumps seeing what all work you all are already doing here. I'm sure you are priming every patient to a better outcome post-transplant.
Yes. Thank you, Shilpa. Shiva, you have done lots on ERAS protocol. You have even come out with certain consensus statements, guidelines. Tell me about ERAS, following an ERAS protocol for pre-transplant.
ERAS is just, in any way, the transplantations of any organs is just the last 5-7 years, which has taken up. So we don't have a strong guidelines on those matters. But there are quite a few studies which have come up in support of what all the parameters need to be concerned of. If you see, you go for any kind of a transplantations, whether it's a cardiac or renal or liver, intestinal transplants, all patients are malnourished. So it becomes a priority that ERAS very clearly states at least 14 days of nutritional intervention should be there. And all these patients are going for an elective surgery. You have ample of time available to you. I don't think any transplant is being done just overnight or within 2-3 days. You have months and months also, sometimes it is available. So why not capitalize on that one? Unfortunately, there are no standards available as of now, but ERAS has come out with some statements, but yes, we are still to look out for these things. The provision of nutritional intervention is immense over here. As we saw the earlier speakers speak about, stating that almost all patients are being malnourished, or there will be some micronutrient differences will be there, which needs to be rebuilt, and a lot of work needs to be done. So I think combining ERAS protocol and the surgical guidelines and the transplantation studies, these three things, when they come together, we can have really a better consensus statements or maybe a guideline for that one. Unfortunately, in India, we don't have any studies are not available. So we need to just wait for that one.
Thank you, Shiva. Cecilia, coming on to you. We talk about it's like this sounds so easy when you tell a patient, oh yes, now you have to go in for a liver transplant and you have to do this. These are the tests that you need to do. What is their mental state? How do you counsel a person who has to now make lakhs of rupees ready, who have to think about their own health, their family around them? What is it? How does counseling for these families happen? Because it's not only the patient you have to talk to, but you have to talk to the entire family. So what are the challenges and what is that you face?
Primarily lack of acceptance. Firstly, to recognize that I have done something which may have been intentional or unintentional in me coming to a space where my body does not wish to support me. Then I need somebody else's help. I'm so dependent on somebody else's donation so that I can live. The financial stress, of course, is without doubt a huge stress, which people will say, no, it's not a big thing. Life is more important than finance. And by not accepting that the finance is causing a big concern to them, they're adding on to the stress. You can't counsel a person like who's going in for a transplant with the same methods that you will go and counsel someone who has other even lifelong issues. Largely with people who have liver transplant, the issue here is a lot of guilt. I have done something which has messed up my liver, because of which my entire family is paying the price. Very often the donor is from the family, and sometimes that donor is not even made aware of whatever complications may or may not arise. So there's a lot of guilt that comes into it. Pre-morbid personality, that's the second part. What was the person's coping skill universally, right from the beginning? If this is a person who's been able to handle life challenges generally with a lot of optimism, strength, and resilience, it's far more easier to work with such a person. Third, recognizing that there is a dependence in this person for social support. A counselor can take the client only so far. What will really help the client is the social support, the caregiver support, and the distribution of the support. If it comes primarily from one caregiver or primarily from one or two family members, it doesn't take the patient very far. If there is support which is distributed across friends and families, it becomes a lot more easier. But again, as in the case of people who use substances and who need liver transplant, that support is lacking. So I hope that answers your question.
Thank you. Thank you, Cecilia. Yes, it's a lot of complexity where mental state is concerned, and today mental health is given priority. So in an MTT, a psychologist and their role is very, very important. Nazneen, I come to you. You know, people after a liver transplant are scared. They're literally scared to be out in society. Can I go out and eat? Can I socialize? Can I meet people? What do you think are the aspects where these patients go through?
So, first of all, Irene, congratulations. This is a great initiative. And yes, socialization is a must, because somewhere, like Cecilia said, the first challenge is acceptance. And almost more than 20% of the patients actually go through depression. So actually going out, stepping out of the house, meeting people actually makes them feel much better. They feel bonded with their friends. So it is a must. However, there are several guidelines which they need to use, especially because when you're eating out or eating out at friends' place or choosing from, other places, foods which they got to be careful about. Like somebody would, think that, okay, he's just recovering and give him a pomegranate juice. And that itself could interfere because, because of the, it may interfere with the immune suppressants or the kiwi or things like that. Also raw vegetables, and today a lot of people look for sushi, and it may trigger the rate of infection. Or if you're looking for Chinese cuisines, and like the looking at soy sauce, and the very fact that soya has one of the highest sodium content, so choosing a cuisine also becomes very important based on these ingredients. So that's a critical factor. Also, something as simple as pumpkin seeds. Okay, if overdosed, if they're not like, if they think that, okay, seeds are a good fat of healthy fats. However, if you're overdosing, then again the copper content may interfere. So these are some of the things which the patient needs to be really careful about. Also, of course, in our country we don't eat so much of canned foods, but again, all canned foods would be high in sodium. So choosing foods on that perspective would be important. Also, salads can be sometimes tricky, because if they are raw, and especially in the first few months, the rate of infection may be very high. So these are some of the things which we got to worry about. In fact, one of my cousins whom we lost to post transplant, he did really well, and after 4 months he felt like eating a vada pav. Okay, and the vada pav chutney itself triggered, and it was a successful transplant. Okay, and just the chutney triggered this whole reaction. He landed up into a bad infection, and after that, it was just, and he was a young boy, 22 years old. So it was a journey downhill. So you got to be really careful with the raw foods. Also, whilst we say nuts and seeds are healthy, I think a lot of times there is a lot of fungal infection. So simple tips like, roasting them, eating them, or carrying it before you leave home. All these would be important for all the patients to follow.
Thank you, Nazneen. Before we have the closing statements of your, I would like the audience to, interact with the panelists and ask some questions which is in your mind. Anybody?
So when Cecilia was talking, actually, one thing that struck me is that for anything we never accept. If you're not well and somebody says, go to the doctor, you always shrug it off saying, no, it's nothing. And sometimes maybe we don't know what it is going to be. So I think it's like, all counselors probably have a big work to do where talk to people to listen to their bodies. That is, I always feel, everybody, even I will do that. I'll say, no, it's okay. And that is probably something as a mindset we need to check.
Also, role of yoga, tai chi, science, these are very unspoken. They are a must. In fact, physical therapy actually should start right from the hospital, and great impetus should be there that the person continues. In fact, the ACSM also gives almost around 150 minutes of exercise. They've actually also staged it based on the progress. And so the exercise is a must. Slowly and steadily after 6 months, be it swimming, cycling, walking, all of these are a must. Because exercise not only improves the mental health, it also helps in kind of, reducing the depression levels. Sometimes, like a lot of studies that I was reading, the failure of the plan is because the person is so depressed, he's actually forgotten to eat his immunosuppressants. And that is why, so there's nothing wrong with the transplant, but just forgetting to eat medicines itself can derail the entire case. So I think those are things where you help the person do some pranayam, do yoga, and it's the whole family. I think the lifestyle management actually works for the whole family. So when everybody is in it, the person overall feels better. And I think yoga is one of the great sciences which also help us to accept. So bringing in acceptance and also acceptance and detachment together are very, very important things.
Yeah, so there is where our counseling techniques come in, because they will definitely go to many people. Whilst Ayurveda is 10,000-year-old system that India follows, we need to go to the right people and we need to know the right things. Also, there is where there is still a lot of work happening in a lot of herbal and Ayurvedic this thing. We can't completely disown it because India has been using it for years together. At the same time, this comes the exact question which I am going to ask Shiva, is that we don't have guidelines. We cannot disregard something just because we feel it may cause harm, or we think it may cause harm, or because it has caused harm to one person, it may not cause a harm to the other. But we don't have a guideline to read. And Shiva, you have worked so much on making Indian consensus statements and consensus guidelines. What is your thought of coming out with some consensus guidelines for these aspects?
Shiva, one moment. I'm just giving it to him. Can you also have an Ayurvedic physician, somebody who's well known in these teams?
It's not yet integrated. Not integrated.
Well, in fact, my question is to the audience first.
Very good. I want the audience to talk. They're only listening.
Tell me honestly, How many of you really follow evidence-based guidelines or evidence-based consensus statements in your practices? Let you be answering the truth. Just not because I'm asking the question, you have to raise your hand.
Yes, somebody wants to say.
I should see
Can
the
we have the
hands
mic
clearly.
there?
Please
Can
don't
we
say
have the
like
mic?
this.
The simple answer to your question is we use them as a guideline.
Sorry.
We use it as a guideline.
Thanks. Thank you so much.
Yeah, we have somebody from
But-
behind also answering, Purvi,
Probably
and
just
I think who's there?
See, yeah, this is what, you know,
Yeah.
why we are lacking. It shows that there is a difference of opinion. Why should there be a difference of opinion for a standard kind of a treatment or a standard kind of a protocol where it will be, where if we can follow and we can have a standard outcome as well. Today we came out with the cancer guidelines depending upon the Western and the Pan-Asian studies. Unfortunately, we don't have the Indian data. I was questioned in Vadodara by one oncologist. Why is it that you just compiled the established guidelines? I said, how many papers you have presented? Or your institute has presented, or even the entire Vadodara or entire Ahmedabad or entire Gujarat has presented, not a single paper. So this is where we are lacking. Is it so difficult to do a study? Yes, a structured study is very difficult in a bigger hospital side, I do understand. But taking 30, 40 patients and compiling their outcomes, it's so easy to publish the things. IIP in India is there. We have our journals over there. We are there to help you out. We ask you to come out with your data. If you want us to compile and do the assessment and the statisticians evaluation is required, even the medical writers we can provide you to write down the entire paper as well. Of course, little bit of costing would require because the people are going to charge for that one. But even those 30, 40 patients data is going to contribute to our own protocols. If you see all these bigger guidelines, Aspen, have you ever seen the papers, what they have referred, how many subjects they have taken? Hardly 40, 50, because they don't have a population over there. And we have such a huge population, but unfortunately, we don't have even a 20, 30 patient studies being available. So this is what I keep on saying at various places when I go around, asking people to come out with whatever the data you people have. As and when you start working, you present the first paper, you learn a lot of things. You present the second paper, you become a semi-master, I would say. Present the third paper, present means you publish, not just the presenting. You are a master over there now. Thereafter, you will get so many ideas to come out with the research, and India is asking for the data. TMH is also publishing. Unfortunately, even in nutrition, we don't have that much of data available to us due to certain other reasons. But there's a scope for us. If you can come out with your own data, we are there to come out with the guidelines and the consensus statements for our own population. Someone who is practicing at Guwahati and someone who is practicing at Kerala, and we at prominent cities, we all have difference of opinion. Why should there be a difference of opinion for a standard care process? Now we talk about all nutrition care process, it has to be standard. Now IPN has taken that initiative. Tomorrow is the first meeting for the nutrition care process. We are going to write it up now for the entire Indian population. And I can assure you this will be different from the ADA's nutrition care process, because we just don't want to copy paste. And there are many things which we have learned through our practices, which can be imbibed in our own documentations. So what I would say that whatever the guidelines, whether it's an IPN or any Indian society guidelines, follow those guidelines. That helps you a lot. That gives you a scientific approach to your work as well. And you'll be respected by your own hospital doctors and the administrators as well. Unless until you're going to practice the evidence-based workout, you'll always be questioned for that one. And many people come and say, no, I've been questioned by my doctor. He always says, why you're doing this, why you're doing that. That is only because you're not able to answer to them. We were once upon a time, we were like that only. We were also being questioned. But as and when we went on learning many things over there, now we give them back. So we tell them what is right, what is wrong. It's a real story, I would say. Eras protocol came in just 1 minute. Eras protocol.
One important point, you get the results, and that is what is speaking for you.
Yes.
Because you're getting the patients better.
Yes, exactly. Your outcome is good. And of course, I keep on saying nutrition is one of the so important factor. In addition to the physical activity, the entire outcome of the treatment relies on that one. Unfortunately, it is still yet to get its own recognition over here. I'll just say one thing over here. A real incident, I would say. In 2015, my intern was just talking to one of the patient whose Ryle tube was removed. And she said, start with the liquid. And the senior resident came and told the patient to start eating. And the patient actually was not able to eat anything because of the swallowing difficulties, what he had over there. And he said, if you don't start eating, I'm not going to see you. And the patient said that dietitian came and said, take the liquids and you're telling me to take the solids. That doctor called up our dietitian intern and he shouted at her. And he told, do you know what is ERAS protocol? And that was published just maybe 1 week back. And fortunately, I just happened to, serve that and get that I'd read a little bit of things. And I called that doctor and I asked them, what do you know about the ERAS protocol? Can you tell that? See, it is talking about early removal of the catheters. It is not telling you to early starting of the solid feeds when the patient is not able to. So this is just a small event which triggered to us to read more about the ERAS protocol. Within the next year, the surgical guidelines came. And when I was talking about the ERAS protocol, I was questioned, ki usme nutrition kya hai? I said, yes, I agree with. Then you combine the ERAS protocol and the surgical guidelines, perfectly you'll understand what is peri-operative nutrition. Or else you're not going to understand. So sometimes you need to combine the guidelines and try to understand. That is what the evidence-based practice is. Just don't stick to only one part of it. There is nowhere such a strong documentation where ERAS protocol is being linked to the cancer surgeries. But yes, it has implications over there. It started with gastrointestinal surgeries, but it went on for the cardiac as well as everything. So I just appeal to all the people who are witnessing this one, just practice evidence-based practices and just be scientific in your approach and have your answers ready. Someone who is not going to let you practice on your own way, in the best possible scientific way, you have to question them at the right possible time. Thanks.
Thank you. In fact, Pooja, you have worked a lot on pre-operative drinks. Can you, tell the audience what is this pre-operative carbohydrate drinks? How is it given? When is it given?
Thank you, ma'am, for this opportunity. Well, my PhD
First,
was...
introduce yourself.
Okay, I'm Dr. Pooja Thakkar. I'm working as a chief dietitian at Breach Candy. 6 years back, I had done my PhD at Bhatia Hospital, where I had developed a pre-operative drink for gastrointestinal patients who were undergoing Whipple surgery or gastrojejunotomy. So for those patients, when I saw ERAS guidelines and European guidelines and American guidelines and all those things, that time I had come across different types of guidelines, but nutrition part was very little. Then I went back to my surgeon saying that, why don't we start giving glutamine, omega-3? He said, leave all these things. It's already been covered. Those nutrition facts does not matter. Presently, the patients what we have are so malnourished. Pooja, you should look at carbohydrate, then look at protein. Don't look at fantastic protein sources because it's expensive. Those patients who come down for surgeries, they have actually traveled the world or actually traveled the India, undergone a lot of surgeries, and then they'll end up coming for liver surgeries. So that's the time we started looking at minor things. How do we incorporate basic food item? Because when I take their recall, you land up, they barely eat 20% of the food. They don't have appetite. Albumin, yes, albumin IV is given to them. And a very important thing, when you're looking at follow-up, we just look at WBC count because eventually CBC is the test what is done on regular basis for them to see whether there's no infection rate. And the most important thing was giving them a night meal because they always landed up into hypoglycemia. So actually I had to call up my kitchen and tell them, please keep a custard out there. Make sure, night 12 o'clock they have it because 8 o'clock they're going for surgery. So they shouldn't be fasting a lot. There was, because ERAS guideline says that there has to be less amount of fasting hours. No, I eventually, they told me, go to the anesthetist, speak to the anesthetist, whether he's ready to take the risk of reducing the hours. But in fact, the liver surgeon said, I can come down to 6 hours. I can't reduce to 2 hours or 3 hours. Whereas I had done a comparative study with an orthopedic surgery also, where TKR and THR is done. So that time they told me the anesthetist uses a general anesthesia and here the spinal anesthesia. So the R's differ. So there are many minute things if you look at surgery, and if you look at different eras, if you go and look at LSCS or hysteroscopy or hysterectomy done, that time you realize there's different anesthesia used. You can't use milk products or anything such. So I feel, every dietitian should specialize in certain way, in certain area of their specialty, whatever their hospital has maximum patients, so you can give the best result to them. So now when a liver patient comes to me, although in this hospital I don't get Whipple surgery, but they are the end stage liver disease or something like that, I'm like, no, this 6 years I've spent on it. We need to do it this way. We need to work on it. I tell them, whatever it is, have mashed potato, have rice, have carbohydrate. You require carbohydrate right now. We look at the protein part later. So that's how you need to build it up. And I know Google is accessible. Everything is accessible. So the patients, land up reading many things. So recently I had a patient where patient has landed up with TB. He's already had a CKD case, and he's always presently he's been detected towards liver failure also. So when his daughter comes up and says, I don't know now what to do because we have Googled about CKD, but it's contradicting the liver thing and it's contradicting TB. Now, please tell me what is supposed to be done. So that's the time you realize now the patient is coming to you. And I'm like, okay, no, but this contradicts this thing. How do you do it? So that time I'm like, okay, you need to do it this way. You're on dialysis. Don't worry about this thing. We'll look at your liver also. So I feel reading up new things, compiling the data, like how Sir said, doing research. I feel doing research is really helpful because you come to understand where different medical fraternity is working, what is their opinion about it. And we don't have a stringent opinion only to dietetics. We know about anesthesia, you know about surgery, you know about the medical part, what is going around. And you can somehow balance and get a good life for the patient, which is more important.
Thank you, Pooja. Pooja, you just summed it all and saying that carbohydrate is not your enemy.
Not at all for somebody who's married.
Yeah, so it's not that bad to have carbohydrates. Yeah, so that's why, people need to come to dietitians to find out when to have a carbohydrate, how to have a carbohydrate, and in which situations a carbohydrate is really good for you. So it is not all that bad. We also have with us Ankita. Yes, you want to say something?
I would like to even add on for a psychologist. Thank you for your opinion, because I recently came across a series on Netflix where I don't remember the name, but Anupam Kher is one of the doctor into it, and they have shown an American setup, and it's all spoken about liver transplant.
New Amsterdam.
Yeah.
New Amsterdam.
True. And in a very nice way, they have shown that how a person is undergoing a liver transplant and there's a donor, and again the patient who's going to donate the liver backs off saying that I'm ready to donate the liver, but then all of a sudden again there's a trauma and again the patient backs off. So in a very nice way, they've channeled it that there's one who is in a vegetative state, you're taking his liver, and there's a circle, and they've made 4 liver cases possible.
Thank you, Pooja. We have Ankita with us. Now, Ankita is a specialist in body composition. And Ankita, can you tell us the importance of the body composition in these cases?
Thank you, ma'am, for this opportunity. So basically, whenever we assess a transplant patient, pre-op or post-op, so it's very essential to assess their face angle. We all know about muscle and fat, but body composition is much beyond. We need to see their water levels, that is their extracellular water, wherein we come to know about their edema status and the phase angle. Phase angle tells us about the nutritional status. So most of the time we look at the patient, muscles are normal, but those muscles are overestimated as the patient is into fluid overload. So the phase angle and the body cell mass, it tells us whether the person is actually nourished or the person is ready for the surgery or no. If the phase angle is below 3.9, then the outcome of surgery, which we are expecting, is not necessarily met or achieved. So it's very essential to get that person nutritionally stable with the help of nutritional therapy and with the medication to achieve that phase angle and then go for the surgery. If we do it before, then there are again the complications seen. So the researchers also say that if we don't assess them timely post-surgery, there are higher risk of sarcopenia seen in the patients. They are in the lying posture. They are most of the time physically inactive. So physiotherapy and the multidisciplinary approach plays a major role in this. So that's where BCA plays a major role.
Thank you, Ankita. Can I have some closing lines from Cecilia, Shiva, Shilpa, and Nazneen? Yes, yes, Jayashri, first introduce yourself.
I'm Jayashri Paranspe. Yeah, working in Nair Hospital for last 34 years, maybe. Yeah, that much introduction is enough. Yeah. So I just want to add to what everyone said about having multidisciplinary approach. Somehow I have always found that dietitians are not ready to go and talk to people from other fraternity. Somehow we are just sitting in our room and minding dietetics. But dietetics, you can give good patient care if you talk to the doctors, to the surgeon, to the anesthetist. As Pooja rightly said, we are not aware there are different kinds of anesthesia and what are the requirements, what are the fasting levels which are required. We are not, we are not aware of what is the role of a psychologist. Now there are also swallowing experts, right? So we need to talk to different people from our team to understand how we can give better patient care. So I really want to request to all the young dietitians, please get out of your rooms, talk to other people who are not dietitians, and you will learn much more and you will be in a better position to give better care. I think.
Thank
all
you,
will
Jayashri.
agree.
Yes, team approach is the thing today, and we need to work as a team. Cecilia, can we have some?
Yes. So to sum up, just people don't like to go to a psychologist. You're taking them for a liver transplant. The guy is going to ask you, "Mere liver mein problem hai, pagalon ke doctor ko kyun bulaya?" That is my first problem. So because the session is about liver transplant, I'll give you the acronym for LIVER. Maybe you'll be able to convince your clients better with this. Long-term intervention to validate experiences with resonance. I'll repeat it. Long-term intervention to validate experiences with resonance, because if we understand why there is a problem in the personality that does not allow the individual to cope with any problem, transplant to baat ki baat hai, you will understand where psychological problem comes from. So let's work towards building openness to personal growth. And I was recently talking to a doctor from an ECMO unit, and I was shocked to know that there is no psychologist on the team. That's terrible. The doctors in ECMO are already undergoing so much of stress. They are providing the counseling support to the families, to the client, to the donor. I think that's unfair. So humble request to all of you here, please make friends with psychologists. They're good for you and for your clients.
Thank you. Thank you, Cecilia. That was really a very good advice.
This regarding, there was a talk after the ERAS protocol when first time it came. It's a summarizing kind of a statement what I'm making. There was one suggestion where they spoke about empowering the patient, what services he actually deserves over there. Today, in the Chennai Declaration, we came out stating that it is a fundamental right of the patient for the nutritional care when he steps into the hospital arena. So it is so simple to state over there, but somehow it is not being highlighted in the right way so that the medical fraternity is not taking up account of this one. So once if the patient is empowered to what questions to be asked when I go to a doctor, say for example, if he's going to ask whether your hospital is an NABH accredited, or are you going to practice ERAS protocol, and how many days and other things and got complications, and what is your success rate? What is your institute success rate in this kind of a treatment, what I'm going to undergo? But due to the scary part of it might lead into a very medical legal aspects, that statement was withdrawn almost at the end of the just before the publication. But this is the need of the hour. If suppose a patient comes to you and asking many questions over there, you become more aware of it. So it's better that we need to, as she also rightly said, that psychological and MDT people, and we also work out in a rehabilitation team, what we have with many personals over there, try to take help from all other allied sources and see that in whatever the way you can empower the patient at the first instance itself, that can make a difference over there. Because if the patient is learned enough, he is going to comply to your dietary advices, or else it's very difficult to make the patient to understand why your role is so important over there. Thanks.
Multidisciplinary approach always needs to be primed. Okay, taking forward what ma'am had said about Ayurveda and the question that you put in about the 6-month rule. It's not just alcohol. Today, probably we are also talking substance abuse. We are talking maybe the patient with alcoholic disease has already taken, whether it's Ayurvedic or nutraceutical or whatever. They have already self-medicated and then come to you. We are talking of rampant use of maybe over-the-counter medications, say during COVID times, not just COVID, we self-medicate. Our liver has already taken a toll over there. We are also probably talking smoking. So there are a lot of addictions we are talking. Maybe that's where the multidisciplinary approach and the psychologist help comes in and becomes very prime. That's where maybe guidelines to approach these patients become very prime. And maybe the first time the patient walks in, your peri-operative nutrition starts when you are talking of a chronic liver disease. Maybe it is 20 years to their transplant, or maybe it is 2 years to their transplant or 20 months to their transplant. If when you see the patient's report and you feel this patient is leading that way, you have to start priming that patient, because you are talking sarcopenia big time. Even if it is obesity related sarcopenia or just sarcopenia, and muscles cannot be built in a day. So this is your opportunity that you start treating the patient, priming the patient for post-op, not just to take him to the transplant bed, but to then have a good post-op outcomes. So our role is very important, and each patient, the goal should be to have good health. Thank you.
Okay. I think this whole holistic lifestyle is a very important thing. So ahar, food, and all of y'all are nutritionists. Y'all are perfect at, that's our job. Also, achar, setting the person in a routine. That would take care of your depression, would take care of a lot of routines. Just setting an alarm just to wake up in the morning, have your medicines, go for a walk. So that achar, the routine, is a very, very important thing. We are slowly, like the first question Irene asked, socializing, getting back, little recreation, creating a hobby so that you channelize all this, depression, frustration, anxiety into something more creative. I think that is a very important thing. So ahar, achar, vichar, and vihar, all of them are very important. And I think, be it yoga, be it Tai Chi, any of these mindful based, programs really help a person to stay tuned. It's very easy to slip off. It's very easy to continue to feel sick and not wake up, and then not get out of the house, stay inside the house, and you're slowly losing touch of everything. So I think just working on your own self, treating yourself as priority, I think is important.
Thank you, Nazneen. And Cecilia, you rightly said, an ECMO also needs a psychologist. In fact, we'll be covering that we are going to be having our following next sessions, which are coming up, is going to be on heart and lung transplant. And we'll talk more about ECMO there. So now coming to all of you, in fact, Ankita has kept a body composition machine outside. If you want to check your body comp, please do so. Also, we can have a little break before we come back for our last and the most exciting session of the ICNC Curtain Raiser. So we can have a short break and come back in another 10 minutes. Thank you.
Thank you so much.
Request all those who are at backstage behind near the stalls to take their seats as we'll be beginning. May I also request the company representatives to allow the delegates to get seated, and we will allow the time for the. Thank you for your cooperation. वो तो निकालो, वो तो लगेगा ही, वो तो लगेगा ही। आइलिन Eileen, session is under recording. Session is under recording. Ask me how to speak. I'm going to ask questions. Till we connect live and virtual with the IPN India, we want to take a few bites from people who were here. It was a very interesting session we had on the Malnutrition Month, and Mumbai chapter had done a great job by having a multidisciplinary team. So just till we connect to the entire NEC team, I want to hear from a few of our delegates. May I request Ashni? How was your experience, and some take-home messages where you can take it to your hospitals and patients? Can you contribute?
I think we've learned a lot from everybody regarding what liver transplant, how to assess, how to counsel the patients to make sure that they are optimized pre-transplant, so that, you know, post-transplant the recovery is faster. And I hope that all of y'all have also taken those bits and y'all can follow that in your practice, because I think we've learned it from the experts over here. Thank you.
Just from what Ashni said, and she's from HN Reliant Hospital, and they have wonderful techniques where nutritional assessment is done. And I think all of us learned. So when we go back, if we are able to take at least one thing to our practice, we read up on that, and we are always there to help each other and connect and take the way ahead. I can also see Purvi on the first row. So Purvi, some inputs, because Shiva did speak upon ERAS, but what was your message to people who are here?
Hello. Well, what we've learned is actually, this is very rightly, as you go to see, it is the era of the core groups which are happening. And there is so much immense which is happening in every field. If you could, initially when we saw, it was just clinical dietetics and therapeutics, just covering the topics. But right now in detail, as the core groups are coming in, the evidence-based researches as well as the guidelines are setting with the Indian-based guidelines which are coming up, is the way ahead for all the dietitians. Thank you. And they can implement that in the practice.
Thank you, Purabhi, for your inputs. Ma'am Anuradha Shekhar, Vice President, Mumbai Chapter.
as the senior most member, I'm addressing each one of you because I really feel that our fraternity has grown and it is today very, very visible. And that's a very good thing because many of you have started your own ventures and are making it so visible that I'm so very proud that I am a member of nutritionists and dietetic fraternity. So very proud. And here, what has happened in this few hours is very commendable because there's a lot of sharing from each and every chief dietitian who's working in each and every hospital and what they're doing in terms of liver transplant. And there's so much of sharing. And what has come out is that you in your hospitals need to build up your multi-models. Don't wait till the hospital gives you the infrastructure in terms of getting connected, but you can all go back, have a small little brainstorming session in your departments and start collaborating with other departments and make sure that the need for the multimodal system works. Because I think that's the strong point that has been made today, that singly we can't help any patient, but together we can definitely try and at least not eradicate, but can do a difference in a patient's life. So my congratulations to the team. And I loved how Eileen has made this program so very enduring as well as very, very, I think interactive. Nowhere did we felt like sleeping, yes? So it's beautifully, very well organized. And this is happening for the first time in Geo. So another congratulations to you for doing it in this particular. So I think we have done a great job. And I hope all of you will come to ICNC and make that a grand success. I hope it happens here again. Thank you.
Thank you, Anuradha ma'am. You've spoken lots in few words, I must say. And we thank all our delegates, speakers, wise and learned to have you over here. Along this stage, my feet are at least shaky because this stage and the responsibility of ICNC 2024 is indeed a big, but we want to still make it better and the best. So to join me on the forum, I'll just request Eileen to stand by my side. So a small introduction, if you all don't know us, my name is Varsha Gore. I am from Navi Mumbai. And a few months ago, when February 2023, the Rocking Conference of ICNC, that is IPN India, happened in Chennai, I had taken one daring thought that, yes, we want to host the next 2024, and we got it. Even though we were small, we thought we'll got it. But when I took the decision, it was, I can get those goosebumps now also. Then I caught hold of Eileen, and there are so many people they come as a helping hand. And so together, me and Eileen from Navi Mumbai and Mumbai decided to host the ICNC 2024. Actually, we were on the flight together, and Navi Mumbai had bid for the 2024, and we were sitting beside each other, and she told me, Eileen, do you want to take it? I said, no, you only take it. I will help you. I will not do it. And then when she won the bid, she caught me from there and she called me. PC Vijay Kumar said, you all both can do it together. And here we are finalizing and Curtain Raiser ICNC 2024. Thank you so much. So without wasting much time, again, we have the great rocking stars for the NEC, that is National Executive Committee of IPN India Association. And PC Vijay Kumar sir is right here. I request you, sir, to open your camera, and we all would like to welcome you, thank you, and be there with us to guide you and trouble you when we want it. I may be a little wrong. I'm too excited. I may be a little wrong. So what I've done is I'm not going to take your CV as an introductory slide, but I just take the points what I perceived in the last meeting. So Dr. PC Vijay Kumar, our president, honorary president of IPN India, he has been in inception 2012, if I am right. And from there, I have heard him in various conferences.
And he is a great speaker. He is a motive behind us. He looks a bit strict, but cool-minded, yet a lot supporting. I like to see that smile. Thank you so much. So, sir, we want to hear from you because you're a great inspiration to all of us, and we need you as our backbone. So we'd like to hear from you for our curtain raiser as a first hero. Thank you so much.
So good evening, Mumbai and Navi Mumbai. So it's very difficult actually to give an introduction about a person without a slide or the words in front of you in the screen. But Varsha made it very clear in few lines. He made me a hero and he made me the day for me today. Thank you very much for your introduction by making a president as a hero of this IAPN India. And one thing you made it very clearly, I look very strict. That was the feedback I used to get from many people, that your face is very strict and very hard. My patients, relatives used to say this very frequently. So nice observation. I appreciate your observations. So by wishing you all a very good evening. And thank you very much for giving me this opportunity to raise the curtain for the upcoming ICNC 24. If I'm able to recollect exactly about the Navi Mumbai and Mumbai office bearers, I will be the luckiest person in this evening. So I'd like to thank the Secretary of Mumbai chapter, Mrs. Eileen, and the Secretary of Navi Mumbai chapter, Varsha Gore. These are the two pillars who is going to take care of this ICNC 24 in the year 2024 February. So first of all, at the outset, I congratulate, because you all know taking up the responsibility to conduct the Congress is not that easy job. We have many chapters on the line, but when it comes to taking up the responsibility to conduct the Congress, the responsibilities are huge. But this time, Navi Mumbai and Mumbai, both of them are joined together to take up this responsibility. Constitutionally, by the laws of IAPN India, the Congress should be taken care by one chapter and one organizing secretary and all other things. But this time, we are able to make an alteration in the bylaws, or otherwise amend some relaxation in the bylaws by giving the opportunity to the two chapters together to conduct the ICNC 23. So in that way, in the history books of IAPN India, Mumbai and Navi Mumbai is going to be an example for conducting a Congress together. That is also possible hereafter in this IAPN India. So this is a nice gesture of combining, because most of the time what will happen in the sense, we will never come together. We always try to be unique or separate to have the entire thing, whatever it may be the positive or the negative of any events, we want to take the entire responsibility on our own. By seeing you, the Mumbai and Navi Mumbai, getting together and to come forward to form this IAPN India's National Congress, it's going to be the unique thing. I just appreciate that. Just to give an introduction, because I come to know that we have invited all our IAPN members, the chapter presidents, chapter secretaries, and the members of each and every chapters. So I take this opportunity just to tell something about our IAPN India. The IAPN India is a pen society. I like to give you an important definition about this pen society, which I also come to know very recently. The pen society in all over the world, the society consists of doctors and the practicing dietitians. I hope you all know that there are many other associations for the dietitians where we don't have any doctors representing in that association. But Parental and Enteral Nutrition Association means it's a combination of the doctors and the dietitian coming together to have a society, to interact with each other people, to take these benefits to the suffering patient in the clinical nutrition. So we have the unique structure of a pen society in India. That is why ESPEN also recognized without any hesitation, the European Society, without any hesitation has recognized IAP in India as their sister pen society. So we are very proud to have a pen society in India. And we have a lot of chapters because forming a society is very easy. We just want to draft a constitution. 4 or 5 people can come together and they can have a society. But taking up this society to the roots, to the chapters, to the districts levels, it's very difficult. For the last 5 to 6 years, it was a tough job. And in the last 2 years, we were able to achieve many chapters for the IAP in India. Each and every month, we are now getting a request to form a chapters. If you are like-minded people, both a combination of doctors and the dietitians are available in 25 numbers, they can form the chapter in the local areas. They can form a chapter in the state level. They can form a chapter even in the district level. So with this definition of chapters, we are able to bring more and more chapters to the IAP in India. So we are having a representation from south to the north of India and east to west of India. So everywhere we started having a chapter. And in these chapters, the one important thing which we have now is to increase the number of representations from the doctor's side. We have a good representations from the dietitians, but each and every chapter should try to get more doctors to our association. I think this responsibility can be given to the dietitians because you all know who are the doctors interested in that area of clinical nutrition, and you can interact with them and bring them as our society members. And we are giving a structure where the doctors can occupy the post of presidents of the chapter and the dietitian can occupy the post of secretaries in the IAP in India, so that we can have an equal representation. The doctors also can get represented in the IAP in India. And I request all the members in the chapters to bring more doctors to the association of IAP in India. And if you come to the IAP in India, we have a lot of other groups. We want to spread our wings in many areas. So we have formed core groups. And we have a journal. The Indian Journal of Nutritional Research is a unique journal in the area of nutrition. If you look into the Clinical Nutrition Journal of European Society of Parental and Nutrition, you all know the guidelines and everything used to come in that particular journal. So like that in India, we are to promote the people to go for a research and to come out with the papers. We have our own journal, Journal of Nutritional Research in IAP in India. Among the other activities like this, one important activity of IAP in India is the IAPN Clinical Nutrition Congress, which is happening every year. And if you remember, I know 2012, the Varsha Gore has promptly able to recollect that particular thing. I think it is 2012 or 2018. In Mumbai, we had a Congress.
19.
So I think it is around the 2018.
19.
19, yeah, 19. So you are having another opportunity. Within the 4 or 5 years, you are having another opportunity to conduct a Congress in Mumbai. So this Mumbai National Congress, and after that, we had a Congress in Ahmedabad and Congress in Pondicherry, Bangalore. Bangalore had a wonderful Congress. So all the 4 or 5 years, we are having continuously, and in between, even in the COVID time, we are able to conduct a virtual Congress, ICNC. So every year, we are ritually conducting this National Congress on behalf of IAP in India in the name ICNC. So every year, this year, going to be in 2024 February in Mumbai, which is going to be conducted by the Mumbai and Navi Mumbai chapters. So recently, the last year 2023, when we had a Congress in Chennai, because that Chennai is, I'm the native of Chennai, so I had the privilege of participating with the Chennai chapter to conduct the IAPN Clinical Nutrition Congress 2023. So in that I had my own hands-on experience in conducting this particular Congress. So if you look into the Congress, there are many things which have to taken care properly. The two important things which can make a Congress successful, one is the scientific program, the scientific content, and second is the celebration of this particular Congress. The hospitality and the stay in the 2 or 3 days in that particular city, they are going to take care of that memories very much than the scientific program happening in the Congress. So in Navi Mumbai, I hope the Mumbai and Navi Mumbai, both of you can give us a wonderful opportunity to have an experience of your hospitality in those 3 days, which we will bring back to our thing. So that is what happened in Chennai also. More than the people talking about the scientific programs, the time and the celebrations which they had in Chennai, they are having the memories for a longer period and they are keep on enjoying that. If you look into the social medias, everywhere the people were celebrating about the stay in Chennai, the way they represented in the Congress and everything they are celebrating. So important thing is the two. One is a scientific program and second was the celebration. And coming to the venue and the delegates, it's very important to have a venue in a good place where the people can move around freely and where they can stay, they can have the Congress. Everything, if it's going to be happen in the same place, then it's going to be the good thing for the delegates. But at the same time, we have to balance with the cost. So to conduct a Congress, what we had an experience, we should have an important statistics in your hand before starting your work. That is the number of expected delegates for your Congress. If you want to attract more students, to increase the number of delegates, the place which you are going to have your Congress should have an economical place so that you can give more concession to the students and you can attract more students. So we had a bitter experience in Chennai where we are not able to give the opportunity for the students to come and enjoy the academic session because we kept the place very costly, the 5-star hotel. And that particular place, we spent everything on the food and the place for the 5-star stay. So that is what the thing we have to balance in Mumbai and Navi Mumbai. Just think that if you are able to attract more and more of students to participate in the scientific Congress, better to keep an economical place where you can give more concession to the students and attract them for the Congress. The LLL is an important thing in a Congress event. But what we learned with our experience, this LLL should be taken care by the Central IAPN India so that interacting with the international community and getting these people to the Congress, everything can be made in a proper way. And we have decided to have the entire responsibility of conducting the LLL by the Central IAPN India. I hope this will decrease your burden also for the 2 days to conduct the particular Congress. And very importantly, the last time in Chennai, we made an agenda and everything. The logistics also we made in such a way to get more and more people from the chapter committees, the chapter presidents, chapter secretaries. We want to attract them to come to the Congress, and we gave them the many concessions to come here and stay in the Congress and to take up the chair and take up the faculty positions and everything. Though we are able to achieve around 50% of the participants from the chapter office bearers members, this time I think it is your responsibility to attract more and more of people from the chapters to come and participate in the Congress. Because in the Congress, which we are going to have an annual general body meeting, this annual general body meeting is very important to make an amendment in the bylaws, to take up the activities for the next year. So everything lies on the annual general body meeting. And if you have a quorum, and if you have more members are participating in the annual general body meeting, and that is the big strength of any association. So we have to attract more office bearers of the chapters to come to our Congress, and you can take any measures to attract such peoples to come and enjoy in the Congress, to participate in the annual general body meeting. And after seeing the theme which chosen by you people, it's a really attractive theme. I think the theme which you are all choose for the ICNC 24 is a multimodal nutritional dynamics. It's an interesting thing because it's very important, because the nutrition we cannot discuss as an isolated thing. It should have a multimodal approach. We need people from various sectors. In that way, it is going to be a multimodal. You need doctors, staff nurses, with dietitians to take up this nutrition. And multimodal participation. And we have a multimodal delivery of nutrition from the parental, enteral, and then combination of these two. There are many modes by which we can deliver the nutrition. And coming to the dynamics, like a pharmacodynamics of any drugs, the nutrition's dynamics is also very important. Where it comes and how it gets entered into the body, and where it reaches exactly at the cellular level, everything can be discussed. And this theme is going to really rock in this ICNC 24. I appreciate and congratulate for selecting such a catchy theme, the multimodal nutritional dynamics for this ICNC 24. So with all these advices and an introduction to the Mumbai and Navi Mumbai people, I'm very happy to raise the curtain for this ICNC 24. Let me try whether I can do it in my laptop. And if you're not able to do that, kindly help me in doing this. I just share my thing. I hope I'm the co-host of this particular session.
Yes, yes, sir. Thank you.
I'm just trying to share. I'm not able to see my desk here, the screen. I think I'm not a co-host with you. Can I make me host?
It's done.
No, I'm not able to. Can I do it for me? Just share the particular video
Yes.
on the screen.
Sure.
Yes, yes.
Yeah.
I'm not able to see it on my screen.
Thank you, sir. Thank you for being here with us. We could sense your presence. You have given us so many messages. Your guidance was definitely a lot of insight. You talked about the structure, you talked about incorporating multimodal. We are going to include many other physician associates, nursing, and other specialities. So together, along with nutrition as a specialty, we can work better. And every year we raise the bar. Next, after President, sir, I would like to invite Vice President. And on the Vice President platform, we have two Vice Presidents. We have Vice President in medical and Vice President in nutrition. So Vice President nutrition, we have Shankar, who's right here, but I'll take few minutes. We can just applause for him being here. But since we are on the virtual, what we will do is that I would invite Dr. Biju Petokot to be here. Sir,
Sir is not there. Well, we'll wait for some time. Yeah, we'll wait for some time, and then I would like to take an introduction and invite sir once again. So, Lekha, my dear friend Lekha, who's always a guiding force. She's like a sister. She's my Apollo friend, and she's a strong pillar behind us. The news of itself, ICNC 2024, she just said, do it. We are there to support you and guide you. And as Dr. P.C. Vijayakumar rightly said, you will shine brighter because we are going, whatever we did little bit wrong, you will surpass it. So thank you, Lekha. Lekha,
Yeah.
I think I can see you on the screen.
Yeah.
We'd
Thank
like
you,
to
Varsha.
We'd like to hear from you.
Thank you, Varsha, and thank you, Eileen. Through IAPIN, it's become like Eileen also got connected with me as my best friend and like a sister. So the best benefit of, to be a part of this IAPIN is we get connected, and it's like more, not only like we are connected professionally, we get a family the other side also. And I'm very delighted to be here for this Curtain Raiser of ICNC 2024. We all know, especially as dietitians, that clinical nutrition has gained importance, and the increasing knowledge of the nutritional care process has stimulated rapid advances in the development and clinical application of nutritional support. So, for those who don't know about us, our annual Congress provides a platform to learn new advancement in the field of clinical nutrition.
We lost the connection. Yeah.
We'll wait for a few seconds.
And give to all the participants to this topics of current interest and meet colleagues from all over the country. So it's my pleasure to welcome you in advance for this ICNC 2024 at the glamorous city of Bollywood. And we see, seeing all you dressed up, I'm like, the feel that we are already there in that celebrity mode itself. Trusting that all of you will find the participation rewarding and an enjoyable experience. As our Navi Mumbai and Mumbai chapters are all set to rapture you with its enthusiastic approach to critical nutrition skills and science. Thank you, Varsha, and thank you, Eileen, for having me in here.
Thank you, Lekha, for being with us. And I would like to request Mr. Shiv Shankar. I call him as a friendly, I told him beforehand, please pardon me if I just call you by name Shiva, because this is how I have been talking to him. But Shiva, sorry, Mr. Shankar, IAPIN India, Vice President Nutrition. So he's the force which has really brought a lot of chapters, whether you talk about district and states, lot of contributions in the field of oncology, 2.5 years of 2.5 decades of expertise in nutrition, the force behind Indian consensus in cancer guidelines, lot of research, academics, and the zeal and the passion is what he is an example of. May I request him to have few words from him? Thank you.
Thank you, Varsha, for those kind words. Lekha, when did you learn to hack my mobile? You escaped. And she has stolen few lines from my preparation. And I'm really disappointed. And you actually removed all the, what all spirit I had. The right spirit I'm talking
That's
about.
why you muted her in between.
Yes, she did escape. It means she had hacked my mobile, right? Okay, yeah. The content is like, yes, if you just go back to Chennai, I'm quite sure those who had attended, you will never forget about what we experienced over there. Chennai ICNC 2023, it still lingers on the minds of each one of us. It was a really special one, even on my personal front. It has given me and all others an everlasting moment to remember. The Chennai Declaration, the malnutrition video, the logo, 3D selfie, all were a great hit. The academic feast was unmatchable, with national, international delegates, faculties coming together. SPEN LLL saw a record turnout. Credit goes to Shilpa Verma for that one. Thanks for her stewardship. A great effort put by our President, Sir Dr. P.C. Vijay Kumar. Heartfelt congratulations to him. And of course, all my friends in Chennai, Lekha, Vijayshri, Dr. Bhuneshwari, Dr. Yamini, Dr. Lata, and many more names which I might have definitely missed out. You guys have really raised the bar. The twin cities, Navi Mumbai and Mumbai, are determined to raise it further now. The entire team is very much upbeat to host this extravaganza. We all are geared up. Amchi Mumbai and Amchi Navi Mumbai are not going to be less in any way. We assure you for that. Of course, we are going to miss out on one thing, that is the Excellence Awards. And yes, but we are going to put up a lot of thinking into it and surprise each one of you. I missed out on dancing during the gala dinner, but we'll make sure you all in Mumbai are going to dance to our tunes. IIP in India is just not a scientific society, as Lekha did mention about. Like all other societies, it's just different. It's one big family. It's a Bollywood masala movie kind of a thing. It has all the tadkas. Isme comedy hai, action hai, emotion hai, and everything you would aspire for. And above all, the gyan, the education, unmatchable. We are going to increase the emotional quotient, build a strong attachment, and escalate the feeling of us and the feeling of ours in each one of you. IIP in India is very sensitive to each of his members. We will never make you feel alienated. We have members from Northeast, Guwahati, Dibrugarh, till Dehradun, down South Kanyakumari, Lakinagar from extreme Rajasthan, entire India, pan-India, we have covered up. They all have made this great event by their attendance and participation of delegates, just not restricted to India. We have regular people visiting Bangladesh, Sri Lanka, Nepal, Bhutan, Japan, Thailand, Middle East countries, attending and gracing the occasion, either in the form of delegates or as a faculty. Even the faculties from ESPN, Pensa, and the first ever, the president, Aspen president, Nilesh Mehta was here. And the ball just start, rolling it out, and we have reached over here now. IIP in India is a platform where skill, knowledge, talent, irrespective of their age and number of years of experience, young and seniors, we value them and promote them to excel, serve this institute so that the needy will benefit. If juniors are our strength, seniors are our strong mentors. IIP in India means all professionalism, robust business in imparting the knowledge in the field of clinical and community nutrition. All those knowledgeable masters and the skillful students of nutrition, here we are, Navi Mumbai and Mumbai, inviting each one of you with grace and pride. We assure you a happy smiling face while returning to your home, but leaving your souls here in twin cities of Mumbai and Navi Mumbai. I, on behalf of organizing team, welcome you all to ICNC 24, hosted jointly by our twin cities, Navi Mumbai, Mumbai. We all are eagerly waiting to welcome to you these cities of dreams which never sleeps. Thank you.
Thank you, Shiva. One more quality of yours, I learned it today. And next time I'm going to take some inputs on the Bollywood Tadka. Thank you. And all our speakers have been so good in their scripts, speech. I wanted to note down the key words, like how we do for a research or abstract. And yes, as Dr. P.C. Vijay Kumar rightly said, that Congress needs one good aspect, and that is science behind it. Because it's the science, research, and the background learning which kind of drives power in our knowledge, compassion, and our practice. We have with us Shilpa, and I definitely can't forget Shilpa. Many years before I met her, just when she was with us for an Eras kind of a lecture, jointly we decided. And I said, yes, I would like to be a part of IIP. And I never knew that I will become a secretary for the city where I live. And thank you, Shilpa, for giving me those inputs. Shilpa is very simple, humble, but she's so nice in her persuasion. And her knowledge is, she's an example where she has taken up
And today we look at her as, SPEN LLL course coordinator, because LLL program, which has brought in India and so much of students, and we all have been learning. I think you are the main force and you are going to take it ahead. So few words from you, Shilpa.
Good evening, all. Good evening to the NEC, PC sir. Good evening. And to say about the ISPEN LLL courses, it is the lifelong learning program of ESPEN. And if you go on their website, all details are available. I need not give a big descript about those details, but not that our courses are any less, but this gives us an international platform. The ISPEN courses are recognized by 60 countries worldwide, and all ISPEN Council countries recognize their course. So it is something that, in the previous session, we spoke about guidelines, we spoke about the need to integrate nutrition, the need to understand what is even going on, not just nationally, but even internationally, and bring those things back to our own workspaces, right? And this is what the ISPEN LLL course is all about. With 120 topics and 40 modules, the ISPEN diploma is 120 CNE credits, where you need 14 live course attendance and not successful participation. And at ICNC, we have been lucky to bring this to our students, to our colleagues who wish to continue their journey in learning. And we will be announcing soon the 4 courses that we would be having, the 4 modules that we would be having as a pre-congress to the ICNC. And it being here in Mumbai, I welcome humbly, I request, I nudge you all to please participate, because out of the 14 modules that leads you to your eventual diploma in clinical nutrition and metabolism, the 4 modules that we would be taking, out of 14, 4 could be completed in your own city, and you should make best use of that. And appreciating the organizing team, the organizing secretariats, and being a part of Mumbai, Meri Jaan. Whether we like it or not, we are here with you, standing with you, wanting to celebrate the ICNC, the magnanimous academic fest that is going to be there. We assure you we are going to do the best we can. We have the biggest driving forces with us, the NEC with us, the president with us. You are in for a ride, and we welcome you to that ride. Thank you.
Thank you, Shilpa. That was a good bullet train, and we thought we directly took a route from India to ESPEN and back to India. Thank you. We also have Srimati, one of our NEC members. So I request from her side, if she could connect and share a few words.
Good evening, all. Thank you, Ms. Varsha and Dr. Eileen. Congratulations on the Curtain Raiser. Good evening, NEC and all the fraternity of IPN India family. So the positive thing, you all have started on a very, very positive note, is that you're planning well ahead. Planning, and planning is what makes it really good. So I think I really appreciate how well you've started very early. I think the next day of the ICNC or on the day of the ICNC 2023, you've planned, you have done, you've already done one meeting with the NEC, you've already done the Curtain Raiser, which is actually your trailblazing. I think the Congress which you're planning for 2024 will have many firsts, positive firsts, which is very good. I wish you all the best, and a multimodal feast is there. And the main thing is, we need to bring in more and more memberships. We need to grow at the grassroots level, which we have wonderful chapters like Shiva has mentioned, East, West, North, South. And IPN India is a very, very unique organization as a Penn Society, is that we are not just one fraternity. We are not just nutritionists or dietitians. we are where the caregivers, where we are a multi-paramedic and medical. So the doctors, the dietitians, the nutritionists, the nursing, the pharmacy, everybody is able to join this organization to care, to prevent malnutrition, both in the community and in the hospital, which is the mission and vision of all Penn societies. So we are a unique fraternity, and we have grown pillar by pillar, and I wish all the very best to the organizing committee and all the committees. We as NEC, we are there for you, and I'm sure it's going to be a roaring success. Please plan, which you have done really initially really well, and I wish you all the best on behalf of NEC. Thank you so much for the opportunity. Good evening.
Thank you, Srimati. That was enlightening. And what we had promised, we always deliver. And we see Dr. Biju on the screen. Thank you, Dr. Biju, for joining us. And I would like to once again welcome you to this forum of physical and virtual platform. We are here for a curtain raiser, and just a few words about you. Dr. Biju Patakat, sir is known for his scientific content, and that is the very reason he has been always guiding us. And one of the initiatives which we all appreciate is the journal and the research work. And sir is the chief editor for our scientific committee, and also he is the main pillar for the Journal of Nutrition. So we welcome you, sir, and we would like to hear from you to guide all those who are over here and connected to us through a virtual platform.
Miss Varsha, Dr. Biju sir is in the Bangalore airport and he will not be able to talk. He's sending all the very best in a message. He has sent his best wishes. Sir is at the airport, but he has typed all the very best for the ICNC 2024.
Thank you, thank you, Srimati. So I just hand over to Eileen to take the program ahead. Okay, so actually we are at the end of the program, and Varsha and me would declare the ICNC 2024 open. And may we have the video, please? Thank you. So be prepared and we are going to rock it. We end the session for today, but as we know, everything begins with a shagun. And may I call the core organizing committee to step ahead for a photograph and a shagun. Okay, please come. Only side. No. I'll invite. So they are very serious about the video. Okay, so just may I invite Shilpa, Shiva. Yeah. Yeah. Thank you so much. Yeah, I think everybody's there. Yeah. We will stand like this. Thank you. Thank you, everybody. Thank you so much. Please join us for light refreshments. Thank you. Sorry, I cannot forget thanking people. So may I invite Dr. Rita to thank everybody here. Thank you.
Thank you, Eileen. The formal vote of thanks has to be given, but I cannot give it to everybody. But I will definitely say that I thank the NEC who was with us throughout for the curtain raiser. Each one of them has encouraged us and a very, very nice gesture. The next is each and every person sitting here today. All those who have attended today and made this event such a success. We look forward to your participation in the ICNC as well. A big thank you for making time today and being with us. I cannot complete my vote of thanks without thanking Jeenal and Kalpesh for the photography, who've really made an effort, stand like this, do this, and capture everything. Our thanks to RTS Holidays and Resorts, as well as to Mr. Ramesh Thakur for the sound. They have been very patiently doing it, even the online streaming, live streaming and everything. Thank you very much, sir. And now, like Eileen said, we can all move for outside. I would also still like to thank Eileen and Varsha for this. Without forgetting, let me thank the Academy of Nutritional Sciences, who was the entire program of liver transplant was theirs. And thank you very much from IPN India, Navi Mumbai and Mumbai chapter to each one of you.
I just want to also include all our volunteers. May we have you all come ahead for a photographs. Sapna, Cheryl, who are the volunteers? I can't see them here. Yeah, actually, whichever team you all are in. Priyal, Girija, come. Anybody who is going to be a part of our team. This is just the beginning. Yeah, for a photograph. No, it's okay. It's okay. Thank you, everybody. So this is not all. We have many more people getting involved with ICNC 2024. We have many workshops and we have many international workshops for which I would also like to thank Cheryl for her contribution to getting us collaborated with international workshops. So we look forward to it and many more workshops in line. If any one of you have suggestions and things for us that we can do which will add value to our dietitians, please come ahead and let us know. Thank you.